Right. Okay.
We'll get started in 1 minute. Okay, I'm going to admit the virtual audience. And when I give you the cue, Dr. Kreutzer, you can begin.
All right, well, good morning, or good afternoon, or good evening, somewhere else in the world. Welcome, everyone. On behalf of Dr. Morale and Professor Bob Anderson and myself, I want to welcome you all to the 15th Annual Masterclass in Congenital Cardiac Morphology. This year, we're going to focus today on univentricular heart, and especially morphology, of course, embryology, and diagnostic and clinical management with a focus on the infant, on the earlier stages of univentricular heart interventions. I want to thank especially our Professor Bob Anderson and Diane Spicer, who is here with us, and also Mr. Bill Devine, ex-curator of the Cora Lennox Heart Museum here in Pittsburgh, and of course, the faculty that have prepared nice presentations for you all. I also want to thank the Congenital Heart Academy for their partnership in really sharing these presentations with the rest of the world. And of course, their organizing group, Katie Scollon and Drew Berghout, for their incredible contributions in terms of organization and putting this all together. But Professor Anderson, it's such a pleasure to have you with us. I know you're remote, but we see you, and love to have you welcome everyone to the conference as well.
Jackie, at the moment, I'm not seeing you on the full screen, and I see we have a message from a participant saying that who can see the transcript. Are we on the full screen?
We are on the full screen, yes.
All I'm seeing is the thing 5th Annual Masterclass. I only see
that
Jackie.
might be a local problem on your end, Doctor. I'm not sure if I can address it right now, but if you'd like to begin your comments.
Okay, well, thank you very much, James. It's a pleasure for me to be with everybody. As Jackie has stated, it's morning in Pittsburgh. It's early afternoon for me in London, but welcome to this 15th annual masterclass. I've been privileged to take part in all of these, and today's is particularly important because we are going to be considering what I would like to call the functionally univentricular heart. And we have a long history with regard to the functionally univentricular heart. And as you will see when you get to my presentation, which I pre-recorded, it brings together Jackie in Pittsburgh and me in London, but a long time ago when I first met Jackie in Buenos Aires. And it's also pertinent to remember the contributions of her father, Billy Kreutzer, who's done so much to bring forward our understanding of how to treat these patients. So in many ways, today's presentation is a revisitation for me, and I'm also sure for Jackie, of what we've done over the past years. And for me in particular, my association with Pittsburgh has been a major part of my own career. So without further more ado, I'll hand back to Jackie and she can get us going.
Wonderful. Thank you, Professor Anderson. So our first presenter is indeed Professor Anderson. And as you know, apart from his incredible pioneer work with cardiac morphology over the years, he's currently a visiting professor in the Institute of Genetic Medicine at Newcastle University in the United Kingdom. Although he has affiliations with many institutions all over the world and continues to teach all of us. So Professor Anderson will be speaking first on embryology and developmental anatomy.
Well, good morning to you all in Pittsburgh. It's afternoon for me here in London. And my task is to introduce you to the development of the so-called univentricular heart. I'd like to start off with considering the potential problems we have with understanding the so-called univentricular heart. And I'd like to focus this on what we do when we send the patients to the operating room. Now, you're going to be discussing that later in this meeting. And you all know as well as I do that as pediatric cardiologists, ideally, when you have a patient with a congenitally malformed heart, you'd like to create biventricular circulations. You also know that oftentimes that is not possible. And in many ways, this afternoon, or this morning for you, we're going to discuss the solutions that you have nowadays when it's not possible to create biventricular circulations. Because you all know that we create the so-called Fontan circulation. I'm going to come back to that in just a moment. But the essence of creating this circulation is that only one of the ventricles is used to pump both of the circulations. But ask yourselves, how often in the patients you submit to go forward for creation of Fontan circulation, when you look at the techniques which demonstrate to you the underlying anatomy, how many of those patients have a truly solitary ventricle or a true univentricular heart? I hope you'll agree with me. The answer to that is exceedingly rarely. Now, I mentioned a few moments ago that we usually call this the Fontan circulation, but I'd like to draw your attention to an article that recently caught my eye in the World Journal for Pediatric and Congenital Heart Surgery. This is now available on the first look basis, and as you see, it is a first-person chronicle, and it's done by my good friend Billy Kreutzer, because of course, when Francis Fontan was working out his approach as to how to create the circulation we're going to be discussing today, Billy was working on this in Buenos Aires, and he was unaware of the steps that Francis Fontaine had been taking. So if I may, I'd like to share you my own first-person chronicle of these activities, because this is a picture of Francis Fontaine. I hope you can recognize that he's standing alongside me. It was taken in my garden quite some time ago, and I was privileged to have Francis Fontaine as one of my early mentors. I first met Francis in 1974. We became very good friends, and he was remarkably helpful to me in furthering my career. So I owe a great deal to Francis Fontaine, and today I will be sharing with you my own first-person remembrances of what happened as we unraveled the functionally univentricular circulation. But I can also share with you a few reminiscences about the Kreutzer circulation, because I can show you here a picture of a group of pediatric cardiologists and pediatric cardiac surgeons was taken quite some time ago. As you see, 1982 at Porto Alegre in Brazil. And this was a meeting organized by this man, Fernando Luqueza. And you'll see I'm sitting there on front row, and to the left hand of Fernando is Francis Fontaine. But there were other significant people there at the time. This is John Kirkland, in many ways the father of modern day pediatric cardiac surgery. And here at the back of the room is Robert Freedom, another very good friend of mine, and the man who did great things to forward the advances in pediatric cardiology. I'd like to draw your attention to the other man in the Fontaine-Kreutzer circulation, because there is Billy, and he was present at this meeting held in Porto Alegre in 1982. Now, those of you who remember these things will be aware that there was a little contretemps going on at that time between my country and Billy's country regarding Las Malvinas. But despite that, we had a wonderful meeting in Porto Alegre, and then I was very pleased to be invited by Billy to join him in Buenos Aires shortly after the meeting. My recollection is that it was 1983, could have been a bit later, but it was at that time that I met Billy's daughter, who is now very well known to you because, of course, it is Jackie. Here is the picture of Jackie taken during that meeting when we were present in Buenos Aires in the early 1980s. So I too have first-person remembrances of the Fontaine-Kreutzer circulation. But let's get down to business, and let's consider the anatomy and the development of so-called single ventricle or univentricular heart. It was contentious in the early 1980s. It remains contentious now because, to me as an anatomist, a univentricular heart is a heart that has a solitary chamber making up its ventricular mass. But as we are going to discuss, you as clinicians, you still oftentimes describe hearts as being univentricular when it is one of the ventricles that needs to support both pulmonary and systemic circulations. In other words, the substrates of the Fontaine-Kreutzer circulation. So how do we deal with this dichotomy? Are we going to be scientific? Are we going to approach it in a logical fashion? And I hope that is the path we will take. But we could take it in the Humpty Dumpty approach. What do I mean by the Humpty Dumpty approach? So I take you to this quotation, which comes from Lewis Carroll, a countryman of mine, Charles Dodgson. He wrote Alice in Wonderland. The other book he wrote was, as you see, Through the Looking Glass. And this is what Humpty Dumpty had about to say, the use of words. When I use a word, it means just what I want choose it to mean, neither more nor less. And that's the potential problem we have when we talk about the univentricular heart. So I would ask you to restore logic to our discussions today, and rather than describing the univentricular heart or the single ventricle, we talk about the functionally univentricular heart or the functionally single ventricle. Because the essence of the lesions we're going to be discussing is that the majority have two chambers within the ventricular mass, but only one of them pumps the circulation. So Diane and Bill, in the sessions and the presentations that will follow my own introduction, are going to share with you what happens with the arrangements across the atrioventricular junctions. And they're going to be showing you univentricular connections, and they're going to be describing to you the ventricular morphology. And you'll find that on some occasions that can truly be a solitary structure, but usually there is one dominant ventricle coexisting with an incomplete or rudimentary ventricle. And that is why we can adequately cope with this by describing the functionally single ventricle. But what they're also going to demonstrate to you is that functionally univentricular arrangements can also be found when we have obvious biventricular atrioventricular connections. And that is why nowadays we should really be talking about the functionally single ventricle. So I have to start this discussion, and I hope what I'm going to be able to do is to provide the logic that underscores our understanding by looking at development. So I'm going to take you back to the start of development. I'm going to show you what happens when we have formation of the univentricular loop. And we can show you now that these changes that take place by using these reconstructions of human embryos. This is the cavity of a human embryo at Carnegie stage 11, 29 days of development, so just at the beginning of the 5th week after conception. And these are reconstructions that have been made by good friends of mine, Professor Wout Lamers and Dr. Jill Hicks-Poors from Maastricht University in the Netherlands. And you can look at these reconstructions. They're available on the web these days, and you can put the heart back together. I'm showing you here the cavity, and this is the cavity of the ventricular loop. And what you can see is that coming into one end of the ventricular loop, draining the systemic venous tributaries, we have the atrioventricular canal. Coming out of the other end of the ventricular loop, feeding the arterial trunks, or rather the developing arterial pathways, we have the outflow tract. Now, we know that with ongoing development, the right and left ventricles, their apical components, blow out from the inlet and outlet parts of this initial loop, and we now call this process ballooning. And the key here is that as the apical components balloon out from that initial cavity of the primary heart tube, so between them we have formation of the ventricular septum. And this is what it looks like 3 days later. We're now 32 days, Carnegie stage 13. We're in the middle of the 5th week of development. And here is that atrioventricular canal, and it's still feeding the inlet of the ventricular loop, but from the outer curvature of the heart, we see the trabeculations of the apical component of the developing left ventricle. And then if we look towards the outlet component of the loop, we can see the formation of a separate set of trabeculations. And these will form the apical component of what eventually will be right ventricle. At this early stage, the developing right ventricle continues to support the entirety of the outflow tract. So now I can offer you a rational explanation as why very rarely we do indeed get a solitary ventricle. Because if there is no ballooning of those separate apical components, then all that we will have will be a ventricle. And because the atrioventricular canal comes in at one part, outflow tract from the other part, we will have double inlet or double outlet from that solitary and indeterminate ventricle, although the inlets or outlets can be septated, as I'm going to show you, can develop if the heart develops onwards. So we can very rarely have a true solitary ventricle, and that represents the failure to form separate right and left ventricles. But that is very much the exception rather than the rule. It is very rare not to have the formation of that apical septum. As I've emphasized, in normal development, left ventricle supports the atrioventricular canal, the right ventricle supports the outflow tract. And from that early stage, we can see very nicely how you get formation of the commonest types of hearts that have univentricular atrioventricular connection. So here I've gone one step forward. We've gone to Carnegie stage 14. We're getting towards the end now of the 5th week of development. And I'm showing you a cut through an episcopic data set of a heart at this stage. Now, with this technique, I can section the heart any way I want because it's been reconstructed. So here I've taken a section across the base of the developing ventricular mass, and we're looking up at the base from the ventricular apex. And there you are looking at the underside of the atrioventricular canal. And still at this stage, the entirety of the atrioventricular canal is supported by the developing left ventricle. The cut that I've taken shows you very nicely the apical component of the developing right ventricle. As I've emphasized, at this early stage, it is supporting the entirety of the outflow tract. So at this stage now, we have double inlet left ventricle and double outlet right ventricle. And this is what it looks like when I take that same data set and I rotate it so that I can cut it to replicate what echocardiographers call the subcostal oblique plane. So I've cut here across the cavity of the right atrium. And you can see very nicely, I hope, that there is no direct communication between the right atrium and the developing morphologically right ventricle. But already, because of that ballooning, the developing morphologically right ventricle has acquired its apical trabecular component. At this early stage, as you saw a moment ago, it supports the entirety of the outflow tract, but the only way into this developing right ventricle is through the interventricular communication. And I hope all of you will recognize what you see here, the similarity between what Diane is going to be showing you very shortly and what I hope Bill is going to show you with the specimens themselves. This is very reminiscent of the incomplete right ventricle you see in tricuspid atresia or in double inlet left ventricle when there are concordant ventriculo-arterial connections. At this stage, the developing right ventricle is supporting both outflow tracts, but it's easy to imagine how the outflow tract can separate and one of the outflow tracts can be committed into the developing left ventricle, leaving behind this incomplete right ventricle that has no direct inlet. And this gives us the understanding of so-called classical single ventricle, double inlet left ventricle. And what you have seen is that the second chamber in this setting is an incomplete right ventricle. Now, some still try to tell us that small chamber is no more than an infundibulum. But as you have seen, this is not the case because the chamber is based on that apical component that has ballooned out from the outlet component of the loop, which is the developing right ventricle. And I can show you that in a different data set, but at the same stage of development. This time I've rotated the episcopic data set so that I can show you a 4-chamber plane. And those of you who are echocardiographers will, I hope, immediately understand this section, because there you see the atrioventricular canal. And as I've emphasized, it is supported by the dominant left ventricle. And now this shows you very nicely the apical trabecular component of the other chamber, which is incomplete, because as yet it does not have its own inlet. But it is going to be a right ventricle because it possesses the ballooning component that eventually will form the apical component of the right ventricle. But what variations are you going to see in hearts that have dominant left ventricle with incomplete right ventricle? Well, that all depends on what happens within the atrioventricular canal. As you see, the atrioventricular canal is supported by the dominant left ventricle. And if it stays unseptated, you will then have double inlet through that common atrioventricular junction. But in the classical variant of double inlet left ventricle, the atrial septum has grown down and has separated the atrial chambers, and then we have double inlet left ventricle, but still with an incomplete right ventricle. And as Diane and Bill are going to show you, in most instances, the incomplete right ventricle will support the aorta, because transposition is usually found, but on occasion it can support the pulmonary trunk. And that shows us the link with tricuspid atresia, because the only difference between double inlet left ventricle, tricuspid atresia, is that in the classical form of tricuspid atresia, the atrial septum has grown in such a way that there is no formation of the right atrioventricular junction. So what you are going to see is that classical tricuspid atresia is due to absence of the right atrioventricular connection. But then it's equally obvious to see how the atrial septum grows in the other direction. It can cut off the left atrium from the atrioventricular junction, giving us absent left atrioventricular connection. That is seen most frequently, in fact, with leftward looping, when the incomplete right ventricle is carried on the left shoulder of the ventricular mass. But all of these variants with a dominant left ventricle and incomplete right ventricle are readily explained according to the location of the atrial septum. And then all the blood is entering the dominant right ventricle. The incomplete right ventricle has to come through that ventricular septal defect. And that's what we can call it these days. It is no more and no less than an interventricular communication or a ventricular septal defect. But let's move on, because if development proceeds normally, the atrioventricular canal expands, and that's what gives the right ventricle its own inlet. But we know that the atrioventricular canal can overdo things, and it expands so much that it goes exclusively into the right ventricle. And then dominant right ventricle with incomplete left ventricle. And those self-same variants I showed you a moment ago can be found usually with double inlet, common valve with two valves, or with absence of either the right or the left connection. And again, Diane and Bill will be showing you examples of dominant right ventricle with incomplete left ventricle. But subsequent to the expansion of the atrioventricular canal, giving the right ventricle its own inlet, again, if development proceeds normally, the aortic root is transferred to the left ventricle, and then the embryo is able to complete septation by closing the embryonic interventricular communication. And that is all complete in normal human development by 8 weeks subsequent to conception. Then, however, we have other variants of the functionally univentricular arrangement, because one or other of the ventricles can stop growing. And that will give us hypoplastic left heart syndrome, pulmonary atresia with intact ventricular septum. And the changes you're going to see in these settings, and they're going to be shown to you again by Diane and Bill, reflect an acquired disease of fetal life. So when you look at hypoplastic left heart syndrome, you're going to see that the left ventricle can be hypoplastic and incomplete. But you've seen already that it can be hypoplastic and incomplete when we have univentricular atrioventricular connection, double inlet, right ventricle. A hypoplastic left heart syndrome is quite different. We also know the left ventricle will be hypoplastic when we have ventricular septal defect or atrioventricular septal defect. But again, what you are going to see in the syndrome is quite different, because what Diane is going to emphasize to you is that the essential feature of hypoplastic left heart syndrome is the integrity of the ventricular septum, and that is found with concordant atrioventricular and ventriculo-arterial connections. And then we have variability in the phenotypes. In the worst types, there's combined mitral and aortic atresia. But we can find mitral stenosis with aortic atresia, or combined stenosis at both mitral and aortic levels. And then the very best type of lesions within this spectrum are the so-called hypoplastic left heart complex. And it is our belief that changes we see reflect the time during fetal life that the left ventricle stopped growing. So Diane is going to show you these pictures again. They are exquisite pictures in her own archive. And this is so-called absent left atrioventricular connection. I now believe it is an atretic left atrioventricular connection, because if you look very carefully, there is a channel there between the left atrium and that tiny left ventricle. And in fact, on developmental basis, it's very difficult to see how the heart could have developed without initially the atrial chambers being connected to the left ventricle. So this reflects an insult happening very early in fetal life after the completion of ventricular septation. And so we see a tiny left ventricle, but there is no fibroelastosis. In others, you can find an imperforate mitral valve with a somewhat larger left ventricle, but still very small, and again with no fibroelastosis. The majority of cases, however, that you see with the hypoplastic left heart syndrome have a patent but stenotic mitral valve, and this lets the blood get into the left ventricle. But here we look at an example with aortic atresia. But now we see the consequences of that acquired disease of fetal life. Because the blood can get in and out of the left ventricle, subsequent to the left ventricle stopping growing, we have this thick fibroelastotic lining. But since the insult happened rather later in gestation, when we have aortic and mitral atresia, we find that the aorta is somewhat larger. And then we can move further into the spectrum where we have a patent and stenotic mitral valve coexisting with aortic stenosis. But look again at the left ventricle itself. It is still thick-walled, and it has that thick fibroelastotic lining. These are the acquired changes of the disease of fetal life, reflecting the fact that the insult has taken place subsequent to the completion of ventricular septation. And because we're getting towards the better end of the spectrum, the aorta is still larger. And then at the best end of the spectrum, we have the so-called hypoplastic left heart complex. Now here, the right ventricle is apex forming. Pathologist diagnosed this as an example of hypoplastic left heart syndrome. It's quite an old heart. Nowadays, this is what surgeons call the hypoplastic left heart complex, because they know that the valves are commensurate with the size of the left ventricle. It's usually coarctation, but if the coarctation is repaired, then it is possible in this setting for left ventricle to support its own circulation. So this is the very best end of the spectrum, and in this instance, it might be possible to restore biventricular circulations, because we have this well-formed left ventricle. But as Diane is going to show you, on occasion, you can still find these with fibroelastosis. Diane's also going to show you the other classical example of an acquired disease of fetal life, pulmonary atresia with intact ventricular septum. And again, the spectrum reflects the size of the normally constituted right ventricle in this instance, but with an intact ventricular septum. And once more, we're looking at the time during fetal development that the right ventricle stopped growing. And so we analyze these in terms of the partite nature of the cavities. All ventricles are tripartite in terms of their makeup, but the mural hypertrophy squeezes out parts of the cavity. And so you will see this again as a nice example of a functionally univentricular heart, but with biventricular atrioventricular connections. So what we'll be showing you is that individuals not only with univentricular, but with biventricular connections can be functionally univentricular. And indeed, nowadays, the majority of those coming forward for conversion to the Fontan-Kreutzer circulation have obviously biventricular hearts. And to us, the key in the fetal acquired diseases is the integrity of the ventricular septum. But you can also have ventricular imbalance with deficient ventricular or atrioventricular septation. And these individuals also can be functionally univentricular. So a very good example is double outlet right ventricle, mitral atresia, or mitral atresia with patent aortic root. You can have gross ventricular imbalance with a ventricular septal defect and severe coarctation. And these patients also can be functionally univentricular, as can those atrioventricular septal defect with right or left ventricular dominance. And all of these are individuals who have biventricular atrioventricular connections, yet still have functionally univentricular hearts. And indeed, on occasion, patients with straddling atrioventricular valves may well be converted to the Fontan-Kreutzer circulation. So all of these can be functionally univentricular, and in the list I've given you here, with ventricular or atrioventricular septal defect. And they are quite different phenotypes from those diseases we've described, which are acquired diseases of fetal life. So if I put everything together, what you are going to see in the next sessions in this initial part of our symposium is that very few individuals have truly solitary ventricles, but many can have a functionally univentricular circulation. And nowadays, the most of individuals coming forward for conversion to the Fontan-Kreutzer circulation do have those acquired diseases of fetal life. What I hope I have emphasized, what I hope you're going to see in the sessions that follow, is that a key feature in determining the phenotypes that we will put in the various categorizations is the integrity of the ventricular septum. Certainly to me, it is that feature that is the key to understanding what is going on with hypoplastic left heart syndrome and with pulmonary atresia with intact ventricular septation. But I hope what I've been able to show you in this initial presentation is that everything now becomes clear with our current knowledge of cardiac development, because it is that knowledge that sets the scene for appreciating the variations in morphology that you are going to see very shortly. So now let's move on and let's see further sessions demonstrating the morphology of the functionally univentricular heart. Thank you.
Wonderful. That was fantastic, Bob. Next will be a didactic pathology presentation, as was introduced by Bob Anderson, and this will be by Diane Spicer. And Diane is a senior morphologist at All Children's Hospital in St. Pete in Florida, and also the curator of the Ludwig van Mierop Archive at the University of Florida in Gainesville. Diane, welcome.
Thank you, Jackie. Do I change my slides on with the mouse or the? Okay. All right, thank you. So I have no disclosures. Today we're going to talk about the functionally univentricular heart, and these terms in the past have been quite controversial, both for the clinician and for the morphologist or pathologist. The term functionally univentricular heart is now used to better illustrate the differences in this group of patients that I have listed here with these types of congenitally malformed hearts. In this group, they usually have one dominant ventricle and one small ventricle, and it's usually not possible to surgically correct the hearts to achieve a biventricular circulation. In the past, there were a lot of controversies with this topic, especially early on when I was training here at the Children's Hospital of Pittsburgh. So when we talk about a true single ventricle, it does occur, but they are rare. They are solitary and indeterminate, have a double inlet and a double outlet, univentricular atrioventricular connections. The only septum present in these hearts is the muscular outlet septum, and they typically resemble a morphologically right ventricle in that they have very coarse trabeculations. This case usually occurs with isomerism of the right atrial appendages. So both for the clinician and the pathologist, the diagnosis can be difficult. So these are two examples of solitary and indeterminate ventricles. And to your left, you can see it's viewed from the apical position and has a common atrioventricular valve. And this case did have isomerism of the right atrial appendages. The image on the right has separate right and left atrioventricular valves, and there was usual atrial arrangement in this heart. Both have a double outlet, and you can see that the outlet septum is the only septum visible in these specimens. So in the past, there were some controversies, as I've already mentioned, associated with the criterion that defined a single ventricle. The definition to define a single ventricle in the past used to be having a double inlet with an atrioventricular connection, and most patients also had a second smaller chamber, and that chamber in the past was denied ventricular status. And it was considered only to be an infundibular outlet chamber, as Professor Anderson already mentioned to us. Hearts with tricuspid valve atresia were accepted as being biventricular with that small chamber, as I have illustrated here on the left, given ventricular status, even though it was hypoplastic and rudimentary and lacking its inlet component. Both of these examples here I show you have a ventricular septal defect. And the problem with this approach can be illustrated when you look at these two hearts, one with classical type of tricuspid valve atresia on the left and the other with a double inlet left ventricle on the left. The similarities in these two cases are that they both have concordant ventriculo-arterial connections. The case with the double inlet left ventricle, also known as the Holmes heart. And this heart with the double inlet left ventricle, that right ventricular chamber, that rudimentary and incomplete chamber, was denied ventricular status. But you can all see that the ventricles look very much the same and almost are indistinguishable. Though what they have in similarity is that both have dominant left ventricles. And if we look at the arrangement in both of these specimens with the dominant left ventricle, the differences are that in the double inlet left ventricle, you can see there are two atrioventricular valvular connections. And with the classic type of tricuspid atresia, there's an absent right atrioventricular connection, both hearts with a dominant left ventricle. You can see in the tricuspid valve atresia that there's a prominent eustachian valve there, and you can see the right coronary within that deep fibrofatty tissue plane at the right atrioventricular groove where the connection is absent. So just another quick mention that you can also have tricuspid valve atresia when you have an imperforate tricuspid valve. In this case, the right ventricle will be hypoplastic and the tricuspid valve is there, but is imperforate. The difference between these two cases is that with tricuspid valve being imperforate, there is a potential for an atrioventricular connection, whereas with tricuspid valve atresia of the classical type, there's an absent connection and no potential for a connection. But both of these produce the same physiological effect. So if we consider the variations at the atrioventricular junction, we have to look at those hearts that have atrioventricular connections that are supported by only one ventricle, those that have biventricular atrioventricular connections that can be concordant, discordant, or mixed in those cases that have either right or left isomerism, or we have to look at the very rare cases that I have pictured here, where you have absence of one atrioventricular connection. In this case, it's the right atrioventricular connection, with straddling and overriding of the solitary atrioventricular valve. So this is known as a uniatrial but biventricular connection, and these are quite rare. So when we talk about double inlet ventricle, it's one type of univentricular atrioventricular connection. Usually there are separate right and left atrioventricular valves, but you can have a common atrioventricular junction with this arrangement. It's always a functionally univentricular heart, and we must assess the ventricular morphology for whether we have a dominant morphologically left ventricle or dominant morphologically right ventricle. Is that chamber solitary and indeterminate? We also must assess the ventricular arterial connections and describe the associated malformations. So if we look at those hearts that have a double inlet left ventricle, they typically have ventriculo-arterial connections that are discordant or with transposition. But as we saw, you can have the Holmes heart with concordant ventriculo-arterial connections. These hearts have a ventricular septal defect that's muscular and typically within the outlet component of the ventricles, and they can be restrictive. And in this specimen that I have here, it was a very restrictive defect, and in this case did have an interrupted aortic arch as well. You can have two atrioventricular valves to the left ventricle, as well as a common atrioventricular junction. And typically those two atrioventricular valves resemble a morphologically mitral valve. The atrioventricular valves can straddle, as you see here in this 4-chamber view. They can be stenotic or even imperforate. It's important to describe the incomplete and rudimentary right ventricle with its coarse apical trabeculations that usually supports the aorta and also can give rise to both arterial trunks or have a double outlet right ventricle. And this hypoplastic and incomplete rudimentary right ventricle is typically on the anterior superior shoulder of the heart. You can have a double inlet right ventricle, and this typically occurs with a common atrioventricular valve, as we see here. And this was the so-called primum type of common atrioventricular junction, where the bridging leaflets were adherent to the crest of the septum, eliminating any blood flow into that slit-like hypoplastic left ventricle. And you'll note that there's no endocardial fibroelastosis in that small left ventricle. You can have two atrioventricular valves, and in this case, You usually will have a double outlet right ventricle or transposition. Having concordant ventricular arterial connections with a double inlet right ventricle is quite rare. The incomplete and rudimentary left ventricle is most often only with its apical trabecular component. And here you can see the right ventricle opened in clamshell fashion with a right atrioventricular valve and a left atrioventricular valve that's mostly committed to the right ventricle. There is a double outlet, and the outlet septum is between the two arterial trunks that are both supported by complete muscular infundibulums. And here you can see that tiny left ventricle on the posterior inferior aspect of the heart, or as Professor Anderson likes to call it, on the hip pocket of the heart. And it only had an apical trabecular component as the mitral valve straddled into the right ventricle and was adherent or imperforate over the crest of the ventricular septum with where it would have communicated with the left ventricle. Now, if we move on to talk about hypoplastic left heart syndrome, we can see I have listed here the 3 different phenotypic variations: mitral stenosis, aortic stenosis, mitral stenosis, aortic atresia, and mitral atresia, aortic atresia. And in both of the first 2 images, you can see there's a tiny mitral valve with mitral stenosis, and in the far right image that there's a dimple at the floor of the left atrium where there is mitral atresia. In the hearts with stenosis, you can see the unicuspid unicommissural aortic valve in this case. Then there are multiple variations we can see at the aortic valve or within the aortic root. And in this middle picture, there's aortic atresia along with the mitral stenosis. And in the right image, there is a slit-like left ventricle with no endocardial fiber elastosis, and there was aortic atresia. There's also another 4th phenotype that's been described, the so-called hypoplastic left heart complex. And in this variation, we can see that all components within the left ventricle are proportionately small. And there are varying degrees of endocardial fiber elastosis and as well ventricular hypertrophy. All of these hearts have a fairly good-sized left ventricle that doesn't quite reach the apex. And if you look from left to right, you can see the varying degrees in hypertrophy of the left ventricle as well as the endocardial fiber elastosis. So with hypoplastic left heart syndrome, you always have an intact ventricular septum with concordant atrioventricular and ventriculo-arterial connections. The right ventricle is the dominant ventricle and typically forms the apex of the heart. There are variations at the atrial septum, at the atrioventricular junction, and at the ventriculo-arterial junction. And many of these specimens will have an associated coarctation. The specimens that have the phenotype with mitral stenosis, aortic atresia, are those that typically have coronary artery to left ventricular fistulas. We did recently publish a large series in 2018 where we looked at the coronary artery anomalies in hypoplastic left heart syndrome, and there can be other anomalies other than just the fistulous connections. So there's variation at the atrioventricular junction, and here you can see a relatively good size mitral valve. Even though it's stenotic, it has a relatively normally formed valvar apparatus. You can see very tiny mitral valves with fused tendinous cords, and even this one has a portion of the mural leaflet fused to the underlying endocardial surface. You can see arcade or hammock malformations, solitary papillary muscle or parachute malformation, and at the mitral valve, you can also see imperforate valvar apparatus, and you can see the one at the top is much smaller than the one at the bottom. So this just shows us that the insult during fetal development was later in one rather than the other. And then we can see that specimen that I showed you before with the absent connection at the left atrioventricular junction. There's also variation within the ventricles. So those within the group that have mitral stenosis, aortic stenosis, can have globular, very hypertrophied ventricles with varying degrees of endocardial fibroelastosis. Those with mitral stenosis, aortic atresia also can have some variation in the ventricular size. The ventricles are typically globular. and do not reach the apex of the heart. And those with mitral atresia and aortic atresia typically have slit-like ventricles. You can see the varying degree in size of all of these three ventricles, and they do not have endocardial fibroelastosis. The very bottom image shows us some other complications we can see existing within this group of hypoplastic left heart syndrome. When you have premature closure of the oval foramen, you can end up with a very dilated flat valve at the floor of the oval fossa. And the first two phenotypic groups that I have listed here are those that have endocardial fibroelastosis. And again, this can be to varying degrees. When we look at the variation at the ventricular arterial junction, what I want to point out is how do we get from the top image to the bottom image, where we have a relatively good-sized aorta, to this very tiny hypoplastic ascending aorta that basically serves as a conduit for the coronary arterial circulation. So if we look at how these things may proceed during development at the aortic root, we can see that we have unicuspid and unicommissural valves that can also have a degree of added dysplasia causing stenosis. You can have bicuspid thickened aortic valves that have a very tiny luminal outlet. These bicuspid or unicuspid valves, for that matter, can progress to become imperforate. This one shows us a very tiny left ventricle with a unicuspid unicommissural valve that became imperforate, and you can see where the only complete interleaflet triangle is marked with the red arrow, and we can progress to that tiny aorta where we have a blind-ending aortic root. So these are just some of the variations we can see, and also shows us where the insults during fetal development may have occurred. So to move on with the last functionally univentricular heart I'm going to talk about is to look at pulmonary atresia intact ventricular septum. And in this group, there is a spectrum of severity, and in between the favorable, the intermediate, and the severe types, there is a very wide spectrum that we can see. So with the most favorable type, there's minimal hypoplasia of all the ventricular components, and the right ventricle is usually tripartite. The subpulmonary outlet component is typically patent, and the pulmonary outflow is typically blocked by an imperforate valve. You can see in the top image, we have a well-formed apical trabecular component, and the tricuspid valve opening is of good size, but it is quite dysplastic. So this can cause additional issues with even the most favorable type. The pulmonary valves in this favorable spectrum, even though they're imperforate, are good candidates for a valvotomy. And you can see in the bottom image, there was an imperforate valve that did have a perforation in the cath lab. In the intermediate type, this is the group where you can have a wide variation of mural hypertrophy within the ventricles. The subpulmonary muscular infundibulum is typically recognizable, but has a muscular roof. The pulmonary artery, as you see in the bottom image, is usually with triradiating blind-ending sinuses. The apical trabecular component in this group is obliterated by mural hypertrophy of the apical musculature, and the tricuspid valve has varying degrees of stenosis and even varying degrees of dysplasia. These ventricles are usually bipartite, so they have an inlet and an outlet component that are recognizable. This group can also be complicated by fistulous communications between the coronary arteries and the right ventricle. And in this particular case, there was an associated vestibular atrial septal defect. The most severe or least favorable type, the outlet component and the apical trabecular component are typically obliterated by that muscular or mural hypertrophy. The ventricular cavity is typically only represented by the inlet component, and the tricuspid valve is typically markedly hypoplastic and can even be dysplastic. These are called unipartite ventricles because they only have an inlet component. And incidentally, within this group of pulmonary atresia intact ventricular septum, you can see varying degrees of Epstein's malformation as well. These cases are typically complicated by fistulous communications between the coronary arteries and the right ventricles. And if we look at this area that I have in the red box, A little bit closer, we can see that the insult in fetal life took place very early because the pulmonary trunk is this thin thread-like fibrous strand. The circumflex and the anterior interventricular coronary arteries are dilated because they have coronary artery to right ventricular fistulas. And then you can see a very dilated right coronary orifice proximally and a very dilated right coronary artery. And you can compare that to the fistulous communications I have pointed out in the upper images. So some final thoughts. These patients with hearts falling into this group are mostly converted to the Fontan-Kreutzer circulation to allow these patients to survive. Adequate description of the ventricle or ventricles, along with the atrioventricular and ventricular arterial connections, is a required thing for both the clinicians and the morphologist or the pathologist. And when we utilize sequential segmental analysis along with the morphologic method, this allows us for complete description or diagnosis that we can all understand. Even the patients these days or the families can understand what we're all talking about. So thank you very much for your attention. And now I would like to take this opportunity to thank Jackie and Victor for inviting me back home. Children's Hospital of Pittsburgh is where I was trained, and Bob Anderson used to come and visit us every year, both Bill and I, and Bill was also very instrumental in my training, and I would like to now introduce Bill Devine for the presentation of the actual heart specimens. Thank you for all of the knowledge you've imparted on me over the years. You're a great pathologist assistant and a great cardiac morphologist. Let's welcome Bill Devine.
Thank you, you're too kind. What I plan to do is give you a survey of functionally univentricular hearts. I'm going to start out with, though, discussing hypoplastic left heart syndrome. And to do that, let's first look at the normal heart. If you could zoom in, please. This is a normal cardiac specimen, right ventricle, left ventricle, and notice that the left ventricle extends all the way to the apex of the heart. Here is the mitral valve, nicely formed with the two papillary muscles. The aortic valve in fibrous continuity with the aortic leaflet of the mitral valve. And because this is a normal heart, we have an intact ventricular septum. Again, extends all the way to the apex of the heart. Now this specimen has mitral valve and aortic valve stenosis. This is hypoplastic left heart syndrome. We're looking at the left side of this heart. You can see here is the left ventricle. Here is the miniaturized mitral valve. You can see that there is thickening or muscle, that the ventricle is muscle bound. If we go as close as we can here, the aortic valve is stenotic. Again, we have this muscle-bound, small globular left ventricle that shows this white endocardial fibrolastosis. Look at this next heart. And it's giving you a two ventricular chamber view. Beautifully shows mitral stenosis and aortic atresia. Again, you can see here is the muscle-bound, thick-walled left ventricle, the globular, hypoplastic left ventricular chamber with the endocardial fibrolastosis. This is right ventricle here. Also, this is right ventricle. You can see that the left ventricle does not form part of the apex of the heart. If we come in close here, there is your atretic aortic valve, and here is your stenotic mitral valve. Now this next heart, again, also hypoplastic left heart syndrome, has not only mitral atresia, but also aortic atresia. And if you look on the surface, and we're looking at the left side of this heart, you can see that the coronary arteries outline this bulge in the ventricular surface, and this is the site of the left ventricular chamber. But the left ventricular chamber, as close as you can, is slit-like and lacks endocardial fibroblastosis. So you can see, you can classify these hearts, these hypoplastic left heart syndrome, by the conditions not only of their mitral and aortic valves, but also the characteristics of their ventricular chambers. Here's another heart. Again, hypoplastic left heart syndrome. Again, we're looking at the left side of this heart. We have actually a nicely formed mitral valve, if you can get closer. We also have here a hypoplastic ascending aorta. So there's aortic stenosis. And if we look at this is the dominant right ventricle. If we look at the left ventricle, we can see again that it does not extend to the apex of the heart. So it's hypoplastic. There's no endocardial fibroblastosis. The mitral valve is miniaturized and normal, and this may be considered, I would say, a hypoplastic left heart complex. Since many of the Fontan procedures are done with patients with hypoplastic left heart syndrome, back off a little bit. This is a cardiac explant of a heart status post-Fontan procedure. If we look at the left ventricle, this is the right ventricle. Here you can see it's very thick, stiff, very abnormal. The left ventricle, go closer. So some endocardial fibroblastosis, very small. And if we look externally, we can see the conduit from the Fontan. Attached to the superior cable vein here. You can see the anastomosis to the inferior cable vein. This is your conduit. And if we open up the conduit, we can see a very substantial fenestration, surgical fenestration in the conduit leading to the atrial segment of the heart. So this just shows an example of a Fontan procedure. Now, let's look at some of the other types of hearts which have biventricular connections, but one ventricle is essentially useless in terms of the circulation. So what we're going to look at first is pulmonary atresia with intact septum. So this is right ventricle, left ventricle. And we open up the right ventricle. Get a little closer. So we have the right atrium. Then we have the right ventricular cavity. We have a stenotic, dysplastic, tricuspid valve. So this is the inlet. This is the apical component, which is overgrown and squeezed out by this proliferation of muscle. And if we look in the outflow tract, we can see a nicely formed outflow tract, except there is pulmonary valvular atresia. We can see the atretic vessel right here, and it's atresia at this point. The ventricular septum is intact. Now, some people call this hypoplastic right heart syndrome, but you have to be careful because there are cases in which, for example, you have pulmonary atresia, intact septum with Epstein's anomaly, where the heart is actually enlarged and dilated. The ventricle is large and dilated. Or we can have cases where we have pulmonary atresia, intact septum, where the ventricular chamber is essentially almost normal in size. So I think using the term hypoplastic right heart syndrome probably should be avoided. And here's your left ventricle. Another type of heart is what we call tricuspid atresia or tricuspid agenesis. This is a true form of tricuspid agenesis. This is the right atrium. This is the incomplete right ventricle. Here's the aorta. Here's the pulmonary trunk, which is dilated. Here is a ventricular septal defect. If we look into the right atrial segment, we have a nice large atrial septal defect. And the floor of the right atrium is muscular. So all the blood going into the atrial segment on the right goes through the atrial septal defect to the left. So both atria drain into the left ventricle. If we dissect up the atrial segment off of the heart, we can see that there is agenesis. There's no evidence of a right atrioventricular junction. We do have, though, an incomplete right ventricle, which is hypoplastic. Again, here's your VSD, here's your outlet. And if we look down deep into here, we can see, if we get a little closer, the crisscross tuberculations at the apex, as part of the apical component. So this heart, as I said, lacks an inlet. This is a true example of agenesis of the tricuspid valve. And the Fontan procedure was first utilized for this type of heart to repair this type of heart with tricuspid atresia. Well, this heart, again, we're going to look at the left side of this heart, and we look at the left atrium. We get a little bit closer. We do not see a mitral valve. We have a muscular floor. So the mitral valve is not present. And up, so there's no endocardial fibrinostosis, and here is a ventricular septal defect. The right ventricle is hypertrophy and large. So we lack an inlet into the left ventricle, and the atrial segments both drain into the right ventricle because we have an atrial septal defect. You can see right there. Another example of a functionally univentricular heart, since the left ventricle has little use since it has no inlet. Back off a little bit. Now this is a heart that shows beautifully double inlet left ventricle with transposition of the great arteries. This is what we usually see with that type of defect. So we're looking here at the right side of this heart. You can see how thick this ventricle is. You see that it's a left ventricle. Get a little closer, please. We have fine crisscrossing tuberculation at the apex. We have a very restrictive ventricular septal defect here. We have one valve, one atrioventricular valve here, and another atrioventricular valve there. So there's a double inlet to a morphologic left ventricle. And if we look on the left shoulder of the heart, we have the right ventricle. There is your ventricular septal defect there. You can see, of course, there are tuberculations at the apex, and this heart gives rise to the aorta. If the connections from the ventricular segments was normal, for example, if this was the pulmonary artery coming off the morphologic right ventricle and the aorta coming off the left ventricle, this would be a Holmes heart. Now this specimen, again, is a cardiac explant. We have one great artery here. This patient had undergone surgical correction. And if we open this up for a look at the atrial segment as a cardiac explant, most of the atrial segment is surgically absent. But if you look at the pectinate muscles, you can see coming around here on the left side, so this is the left, this is the right, and the pectinate muscles coming around on the right side tells me, even though this is the only part of the atrial segment I have, that this is the right isomerism of the atrial appendages. Now, this is also a very unbalanced atrioventricular septal defect, dominant right ventricle. If you look in here, you can see the coarse tuberculations, and you can see here, if you get a little bit closer, please, there is the valve, there's a single valve, okay? And if we look over here, we made a window here. We have the left ventricle. You can see the fine crisscross tuberculation at the apex. You look up in here, we can see just a small portion of the atrioventricular valve sits above that left ventricle. So both atria drain into the dominant right ventricle through a common atrioventricular valve in this unbalanced atrioventricular septal defect in a heart that also shows right isomerism of the atrial appendages. Now this is a heart. If we get closer, please. Which we have double outlet right ventricle. So this is the pulmonary artery. The aorta comes off back here. We look over to the left side. We can see we have a mitral valve, but it's imperforate. So this is mitral valvar atresia. There's also a small ventricular septal defect, a very hypoplastic left ventricle that does not extend to the apex. The ventricular septum is not intact. Like I said, there's a ventricular septal defect. Here's the aorta. If the aorta had some stenosis or atresia and required a Norwood procedure, someone might call this hypoplastic left heart syndrome variant, but this is not hypoplastic left heart syndrome. This is not really a variant of hypoplastic left heart syndrome. This is a case of tricuspid atresia with hypoplastic left ventricle, double outlet right ventricle. Now here's another example of double outlet right ventricle. You see we have this prominent right ventricle. We have the aorta and pulmonary arteries coming off the right ventricle, two muscular outlet septum with the muscular outlet septum here. We look over to the left side, we see we have a small stenotic mitral valve. And down at the apex here, down in the apex, coming into the apical portion is a small remote muscular ventricular septal defect. Again, this would not be a variant of hypoplastic left heart syndrome. This is just strictly double outlet right ventricle with mitral valve stenosis and a ventricular septal defect. And this is also a very interesting heart. We open up the right side of this heart. We can see this dominant right thickened right ventricle. We know it's the right ventricle because these coarse tuberculations going up the septal surface. There is a tricuspid valve. Now, if we look over to the outflow tract, we can see that we have the aorta coming off of the right ventricle. That is a discordant ventricular arterial connection. This is transposition of the great arteries. But we also have an interesting thing occurring. We have a straddling of the mitral valve. And if we look onto the left side, we can see that the mitral valve straddles through the ventricular septal defect, creating an element of left ventricular hypoplasia, because you can also see in this case that the apex or the left ventricle does not extend to the apex of the heart. And you can visualize that the more that mitral valve is committed to the right ventricle, the smaller the left ventricular chamber may become. Then finally, I have a very interesting specimen just to show you. This is a heart in which we have normal relationships at the great arteries. But if we look at the right side of the heart, we have a tricuspid valve. We have multiple very large ventricular septal defects. If we look at the left side, we have a nicely formed actual mitral valve in continuity with the aorta. And again, we have very large ventricular septal defects. So functionally, this could act as a univentricular heart because of these very large defects. That's the last heart I have to show. But point being that even though none of these hearts are truly univentricular hearts morphologically. In fact, I don't have one. I've seen the pictures of them. They're so unusual and so rare to have a heart that's strictly a true single ventricle that I can't even show you one. Thank you.
Thank you. Thank you so much, Bill and Diane and Professor Anderson. Those were just absolutely amazing specimens. There have been some questions online. There was some discussion about the pathophysiology of endocardial fibrolactosis. And I just wanted to comment on a recent publication from the work that Rajiv Chaturvedi at Sick Children's in Toronto did with Miriam Reuter, that was published in Communications and Biology, where he actually injected coils in the left atrium in fetal lambs and created this beautiful model of hypoplastic left heart syndrome. And so interestingly, truly that starting to understand all the pathophysiology and what happens to develop hypoplastic left heart syndrome. I think that in those specimens, there was no endocardial fibrolactosis, interestingly, although the flow restriction was in the left atrium. So it makes me wonder if you would occlude the aortic end, whether you would develop EFE in those hearts. But that's a really beautiful work. And I think it opens now, having a fetal model for hypoplastic left heart syndrome can help us a lot. So I think it's an incredible work that I would encourage you to pull the manuscript from Rajiv at Sick Children's. Any questions, of course, are welcome from the audience. We have a question for Professor Anderson. I see you say hypoplastic left heart complex and don't use the word Schoen's complex. Is that a reason for that? Or just wondering?
Well, the shown complex is rather different. I mean, as you know, that's the combination of 4 lesions that rarely go together: coarctation, mitral valve malformations, the stenosing membrane, so-called supravalvular membrane in the left atrium, and then the 4th one I'm forgetting at the moment. But that's quite different from the hypoplastic left heart complex as described by Christo Chevenkov, which really, as was shown beautifully, both Bill showed a very nice specimen and Diane's specimens, I think, showed you that beautifully. This is the best end. And nowadays, probably we wouldn't be calling this hypoplastic left heart syndrome. But when we looked at the cases that had been diagnosed by pathologists as hypoplastic left heart syndrome, we found a proportion, perhaps 10%, that would fall into this category. But it is quite different from the Schoen's complex, which is the combination of lesions. But again, that goes along with left heart hypoplasia. And in a way, that points to the need to distinguish between hypoplastic left heart, hypoplastic hypoplastic left ventricle and hypoplastic left heart syndrome, because I firmly believe that the intact ventricular septum is a key part of the syndrome, because I think, as you saw, it is the consequence of an acquired disease of fetal life. And you commented on the fact you can also get that fibroelastosis in the right ventricle. We saw that, in fact, in one of the hearts that Bill was presenting, and I agree with you that that is one of the features that shows us that both pulmonary atresia with intact septum, hypoplastic left heart syndrome are acquired diseases of fetal life.
Yeah, wonderful. Diana and Bob, do you think, though, that in hypoplastic left heart syndrome you could potentially have a tiny perimembranous VSD?
Oh, indeed. I think that is a good point. That if the ventricular septal defect is sufficiently restrictive, that would be part and parcel and would produce the same situation if you had the consequence of flow in and out of the left ventricle. But full well, when you have those tiny perimembranous VSDs, you still then have the fibroelastosis that we see as the major feature of the left ventricle in this setting.
Yeah. We saw a specimen of mitral atresia with a with a good size left ventricle, right? And how you can also get tricuspid atresia and potentially a good size RV if you have I suppose you need a VSD. Is that what you need for that to develop? Although those hearts are very rare. I don't know if you have any comments on that, Diane.
The specimen that I showed in my presentation had absence of the right atrioventricular connection, but the right ventricle was actually quite large because of the straddling left atrioventricular valve across a large VSD. So it didn't show the typical features of classic tricuspid valve atresia because of the large VSD and the straddling atrioventricular valve on the left. And it's what I've learned from Professor Anderson over the years is if we just purely describe everything we see, it's easy to understand what the components of that congenitally malformed heart are and how they're related to one another.
Wonderful. Libby, you have a question, Dr. Lanford. You get a microphone for her? We had been talking earlier about whether you can use, are you going to ask about the coronary arteries? Well, you could use the coronary arteries sometimes to identify. I don't know if that was a question she had brought up earlier. I'd love to hear, Professor.
Well, certainly we can start with that question. I had another one, but in echo, sometimes it's hard for us to identify, where one ventricle ends and another begins. Do you, in pathology, use, I sort of think of using the left anterior descending as a coronary that should divide between the two ventricles. Is that a landmark that's helpful for you guys?
For me, at autopsy, it is. The coronaries, the anterior interventricular and the inferior interventricular always follow the septum. So you can assess at autopsy just by looking at the outside of the heart, almost what your ventricles are going to be size-wise relative to one another. So I use that quite often. And as we talked about earlier this morning, I use those coronaries to look for those teeny tiny left ventricles that have no inlet and have aortic atresia. So they are quite hard to find sometimes. And even in that heart that I showed in my presentation with the double inlet right ventricle, when I showed people at my institution the video I did on the specimen, they were kind of blown away as to how I found that tiny ventricular chamber, which was only maybe 5 millimeters. But I told them I always look at the coronaries, and it helps me to find where to go.
It's a good point.
Wanted to ask. Go ahead.
Diane, can I make a comment there?
Please.
The point Diane makes there is it's often easier for the pathologist to identify, to distinguish a dominant right ventricle from the solitary ventricle, because you have that added value of looking for the coronary arteries. So as Diane pointed out, oftentimes it's exceedingly difficult to find a tiny slit-like left ventricle in the hip pocket of the ventricular mass. But when you have the heart in your hands, always those delimiting coronary arteries show you where to go. But of course, in the clinical situation, you don't have that. Fortunately, I guess you don't have that added value. So I think it's easier probably for the pathologist to distinguish between a tiny left ventricle and the true solitary ventricle.
I think I have an example I'm going to show that probably has that slit-like LV that we never saw. So my question actually was going to be about crisscross hearts, who can have two good-sized ventricles, but because of their anatomy can't be septated. Where do you?
I mean, the question as to whether they're functionally univentricular would then depend on the size of the two ventricles, would it not? As in crisscross hearts or twisted atrioventricular connections, certainly one of the ventricles can be grossly hypoplastic, and then they would fall into the ballpark of the functionally univentricular heart. And then you would be making, I guess, a clinical decision that if you decide that you're going to go along the Fontan-Kreutzer route, then you've made the decision that the heart is functionally univentricular.
In my experience, the majority, even with two good-sized ventricles, end up with a Fontan because of the difficulty of septation. So it's just an interesting category. And I don't think I've ever heard you speak about the crisscross heart. That's
because we haven't thought about it in that context before, but it's a very good point that you make. And I think in many instances, oftentimes the option will be for the Fontan-Kreutzer circulation, where Diane and I, Diane, you can speak for yourself, we might not necessarily think that it's a functionally univentricular arrangement.
Right, wonderful.
Yeah, the two that I have fairly good-sized ventricles, one with transposition and one with usual ventricular arterial arrangement. So
yeah,
I don't know.
Wonderful. Well, I think if there are no other questions, we can continue obviously talking after the imaging section. So we're still going to keep going on morphology. So many more questions related to morphology are very welcome, but we're going to focus now on the imaging side. The next speaker will be Dr. Jackie Weinberg, and Jackie is currently our acting director for fetal cardiology here at Children's Hospital of Pittsburgh, and she'll be talking about fetal diagnosis.
Okay, good morning, everybody. We are going to talk about, as Jackie said, the fetal diagnosis of the functionally univentricular heart. hopefully. Okay. So luckily, this is one category of congenital heart disease in which the majority of cases are detected prenatally. These are a couple representative studies that, as you can see, indicated by the stars, there's a high rate of detection in fetal life or prenatal diagnosis for these lesions. This is because these lesions are almost always visible on the four-chamber view, which has long been part of the screening obstetric ultrasound at mid-gestation. This is a normal four-chamber view, and as we play it, we can see on the screen 4 chambers. There are 2 atria, 2 AV valves, and 2 ventricles. And we do spend a great deal of time looking at the morphology of these chambers and determining which is a right ventricle and which is a left ventricle, as well as the connections between the atria and ventricles and arteries. As opposed to in this view, this is a fetal echocardiogram at about 20 weeks gestation. And in this example, we do see 2 atria and 2 AV valves, but only 1 recognizable ventricular chamber. Annotated here, we can see anterior and posterior, right and left on the fetal chest. And again, as the sweep starts, 2 atria and only a single ventricle, which was felt to be of left ventricular morphology. As it sweeps through, we can see that there are 2 outflows, although they are discrepant in size, with the early branching vessel, the pulmonary artery, seen smaller than the aorta and posterior to the aorta, which is an abnormal relationship. This is the same fetus a little bit later in gestation, and we had diagnosed double inlet left ventricle. On the left screen, we can see that there are, again, 2 atria, 2 AV valves, and a single recognizable ventricular chamber, which was felt to be left ventricular morphology. And as it sweeps through, we can see a smaller pulmonary artery and an anterior larger aorta. On the right side of the screen, this tips towards the ventricular septal defect, and we can, in this view, see that hypoplastic anterior right ventricle, which in this example, the left ventricular chamber gives rise to the pulmonary artery and the right ventricular chamber gives rise to the aorta, thus discrepant ventricular arterial connections. There was also subpulmonary narrowing or crowding, leading to pulmonary stenosis in this case. A different example of double inlet left ventricle in the fetus. On the left-hand panel, we can see, again, 2 good-sized atria, 2 AV valves, and a single dominant or a dominant left ventricular chamber, only a single ventricle seen in this view. In the middle, we can see where the red arrow is, the plane of that ventricular septal defect, and the smaller right ventricular chamber. And on the right side, this is a sweep up to the outflows. And in this case, we see the aorta arising posterior and more related to the left ventricle. And the pulmonary artery is anterior, consistent with normal ventricular arterial connections in this case. Also, as was mentioned before, called the Holmes heart. This is another example of maybe a double inlet left ventricle. In the clip on the left, we can see, again, a single or a dominant ventricular chamber that appears to be left ventricular morphology. The attachments of the AV valve go to that anterior wall and do not connect to the ventricular septum. There is a VSD and a hypoplastic RV, morphologically RV chamber, as was seen in other views as well. And when we sweep up to the outflows, in this case, the pulmonary artery, which is the larger artery that branches early, was seen coming off of this dominant chamber, with the aorta more leftward coming off of the hypoplastic chamber. The question was, does this represent a double inlet left ventricle, although only a single AV valve was seen, thus atretic left-sided AV valve, or a different entity? But either way, represents a single or a dominant left ventricular morphology. Moving on to tricuspid atresia. In this example, as we can see in the left pane there, we can see again 2 atria. The dominant ventricle, the larger ventricle here, was again felt to be a left ventricular morphology with a hypoplastic anterior right ventricle. There was no connection visualized between the right atrium and the right ventricle, and so was felt to be tricuspid atresia. Same fetus we can see in the middle pane here, and sweeping up towards the outflows. And here we see a VSD between the right and left ventricles, and the larger pulmonary arteries come off of the hypoplastic right ventricle. So concordant VA connections. On the right was sort of a short axis sweep up, seeing the VSD and seeing a smaller aorta come off posteriorly. This sweep is actually anterior to posterior, and so we see the pulmonary artery and then the aorta as you go back towards the atrium. In this example of tricuspid atresia, there was again a only recognizable single ventricular mass there, and a normal LA to LV connection with no connection seen from the right atrium to a ventricle, and thus felt to be tricuspid atresia. This fetus also had pulmonary atresia, and so the right ventricle was very severely hypoplastic and hardly recognizable. In the same fetus with pulmonary atresia, we often see flow provided to the pulmonary arteries from the arterial duct, which in this case comes off the underside of the aorta, and the blue flow seen up there is retrograde flow to the pulmonary arteries. One last example of tricuspid atresia, where there is a normal LA to LV connection and good-sized left ventricle with a hypoplastic right ventricle. And on the right side, there are the pulmonary artery appears to come off of the left ventricle, and the aorta arises from the hypoplastic anterior right ventricle. It's a little difficult to see in this one, but this is an example of discordant VA connections with triatresia. Here is an example of pulmonary atresia with intact ventricular septum. So on the left, we can see recognizable 4 chambers. There's a right atrium. There is a tricuspid valve between the right atrium and right ventricle. However, this is hypoplastic and poorly mobile. The right ventricular cavity is severely hypoplastic and very hypertrophied, muscle-bound, and poorly contractile, with a normal appearing left ventricle. In the clip on the right, it's a similar view in a different fetus with the same anatomy. In these fetuses, we do look for abnormal coronary flow or connections, and although this is not officially diagnosable, in most cases in fetal life, we can see with the color scale low on this clip on the left that there's color flow within that ventricular myocardium, suggestive of abnormal coronary connections. On the right, this is the typical appearance of the pulmonary arteries with pulmonary atresia. On the right side of this clip, there's the red flow represents retrograde flow from the arterial duct. And now moving to the more common variants of the functionally univentricular heart that we commonly see, hypoplastic left heart syndrome. This is an early gestation, about 20 weeks gestation clip on the left, where there is a dominant ventricle with right ventricular morphology and a normal-sized right atrium. The asterisk shows you where we believe the very severely hypoplastic left ventricular mass to be. In another example on the right, again, they're seeing a dominant right ventricle with a very hypoplastic, severely hypoplastic left ventricle. And these were both examples of mitral atresia and aortic atresia. However, as others have discussed, in some cases, the left ventricular hypoplasia may be less significant or less severe. In this example on the left, this represented a fetus with a hypoplastic stenotic mitral valve and aortic valve, and the left ventricle is recognizable, although notably smaller than the right ventricle, even at mid-gestation. The example on the right is of mitral stenosis with aortic atresia, where there is a very hypoplastic and poorly mobile mitral valve visualized, a hypoplastic but notably hypertrophied left ventricle with the endomyocardial fibroelastosis that's been discussed. Also of note, the right ventricular function is abnormal in this fetus. We sometimes see this play out in real time in the fetus, this progression of disease. So on the left is a fetus that we scanned at about 20 weeks gestation, and at this time, the left ventricle was noted to be significantly dilated with very poor contractility, and it does appear echo bright even at this point. This fetus had significant aortic valve stenosis, and as we saw a few weeks later, that left ventricle had become not dilated at this time, but was starting to become hypoplastic. And as seen in the far right image, the LV is no longer anywhere near apex forming, remains echo bright and poorly contractile. The typical appearance of the aortic arch in hypoplastic left heart syndrome, we can see the red flow represents retrograde flow in the aortic arch fed by the arterial duct. And this fetus with mitral stenosis and aortic atresia, this is the same clip as another I showed a few slides back. This fetus also had another finding that we can see in the right panel. The very small jet of color between the left atrium and the right atrium represents a very restrictive connection between the atria. And we were very worried about a restrictive atrial septum in this baby. When we used Doppler to assess this, there was a high velocity and a very narrow color jet that crossed the septum, as you can see in the clip on the left and the Doppler on the right. And the pulmonary vein Doppler was significantly abnormal. So in fetuses with restriction to egress from the left atrium through severe mitral stenosis or mitral atresia, in fetal life, one way that we assess this is through the pulmonary vein Dopplers. And as the pressure increases in the left atrium due to poor egress, the Doppler pattern becomes more to-fro. So a normal pattern is seen on the left with decreased flow with atrial systole, but not cessation or reversal. However, as commonly seen in hypoplastic left heart syndrome and other similar conditions, we can start to see atrial reversal as well as decreased forward flow. And we use the ratio of the VTIs, the Doppler tracings, between forward and reverse to assess this. Tracings where the ratio is greater than 5 are felt to be not as concerning for restriction, whereas ratios of less than 3 are very concerning for significant atrial septal restriction that will cause instability in the postnatal period and a high likelihood of requiring urgent intervention. A couple of other entities, very briefly, that are physiologically similar to the hypoplastic left heart. This is an unbalanced AV septal defect with a dominant right ventricle. As we can see in this example, there are 2 atria. There is a large primum atrial septal defect between the RA and the LA, and there's a dominant right ventricular mass with a very hypoplastic left ventricle. On the right side, we can see a hint of a very small aorta and a large pulmonary artery arising from that right ventricle. One last example. Oh, and sorry, this is the tipping up to the outflows. The pulmonary artery arises from that right ventricle. And as we can see in the clip, as well as in the still frame on the right, there is reverse flow in the ascending aorta. This fetus had aortic atresia. My last example, this is an example of double outlet right ventricle with a hypoplastic left ventricle. There is a very small but hypoplastic mitral valve and a larger right ventricle seen there, connected with the tricuspid valve. And on the right-hand side, as we sweep up, both great vessels originate from that dominant right ventricle and are of good size. So in looking at these pretty pictures of fetal univentricular hearts, it's important to remember why this is important. The assessment of these congenital heart lesions in fetal life allows for us to determine an accurate diagnosis especially for delivery planning and the care of these babies in the immediate postnatal period to get them to the right delivery location and with the right support that they need. And all in an effort to improve postnatal morbidity and mortality. It also allows us the opportunity to counsel these parents and start their journey into their experience with a baby with congenital heart disease and help them understand both the short and long-term prognosis for these lesions. Thank you so much. Sorry, I was supposed to introduce you. I'm introducing the next speaker, Dr. Libby Lanford, who is one of our senior echocardiography attendings, and she's going to be talking to us about the postnatal echo imaging for patients with a univentricular heart.
Good morning. Wanted to thank the speakers for allowing me to talk about two of my favorite subjects together, echo and functionally univentricular heart. Bob, please forgive me. I'm going to use the word univentricular because this talk's going to go too long anyway. I can't get the whole sentence in. I'm going to steal from Bill. This is going to be a whirlwind survey of echo images of some classical single ventricles and hopefully a few helpful tips along the way. So starting with the most classic and the most common that we see is hypoplastic left heart syndrome. And you can see that there is a patent mitral valve with good leaflet, well, some leaflet movement, a very hypertrophied echo bright hypoplastic LV, suggestive of EFE, and a dominant RV. You can see that the LV is not apex forming. When we tip up into the LV outflow tract, we see the LV cavity, you see the ascending aorta here, but we were never able to identify any aortic valve leaflets. You can see that there is sort of a wall between the LV cavity and the ascending aorta. Moving on to a parasternal long axis view, which is very helpful in many of these hearts. Again, you can see the LA patent mitral valve, LV cavity, ascending aorta, again, no visible connection between the LV and the ascending aorta. LV again is posterior, not apex forming, and then a dominant right ventricle. Again, just another quick look, a parasternal short axis sweep down to the LV apex. You can see here is the hypoplastic LV, echo bright, EFE, dominant RV wrapping around. As has been mentioned, this is the lesion where we worry about coronary artery fistulas. And so here, going back to that initial apical four-chamber view with color flow on the myocardium, you can see multiple color jets consistent with coronary artery fistulas. This child actually went on to have a Norwood and had really no ischemic complications. One of the tricks I always like to teach our fellows is that in many of these patients, the ascending aorta is incredibly hypoplastic, and so it's very hard to find the arch view. So my favorite view is the high parasternal where you find the MPA and the RPA. The little black dot next to the MPA will be your ascending aorta. Typically your dot's at about dot of the probe is about 3 o'clock. You rotate on it, and hopefully you'll get a picture that looks like this. And you can see this severely hypoplastic ascending aorta transverse and a large ductal ampulla. Moving on to another variation of hypoplastic left heart syndrome, and I think this might be one that Dr. Weinberg may have shown. Starting in the apical 4-chamber view, you can see it's easier to see on the color at first. You see 2 pulmonary veins coming in, so here is the left atrium. You see an ASD with a lot of flow going across. But if you look down below where that left atrium is, you see the bar. You don't see any mitral valve. And I think that this is similar to the example that Diane showed, because if you look, you'd expect an LV to be here. I don't see any abnormal thickening here to suggest a hypoplastic LV chamber. Again, doing our parasternal long axis view, which is very hard to do when you have no septum, but this is actually lined up correctly because here's your hypoplastic, very hypoplastic, I think this was like 1.5 millimeters, ascending aorta, tricuspid valve, RV, pulmonary valve, no sign of an LV. So when you're hunting for another ventricle, you need to sweep entirely through the heart. So you want to go from all the way anterior to all the way posterior. So on this baby, there's a sweep from the pulmonary valve all the way down, and never do I see, I'll let it play again, sort of you want to look at the wall to see if there is any little thickened portion. I never saw anything that I would recognize as an LV. So this is sort of a classic mitral and aortic atresia. Just to show the different variations we can see, this again is this was the mitral aortic atresia that we saw. This was the mitral stenosis aortic atresia that we saw. I'm going to try to use the right phrase. This was a hypoplastic left heart complex, which is mitral stenosis and aortic stenosis. And actually, it's kind of an interesting one because you can see that there is a patent mitral valve, but that's fairly abnormal. It was borderline in size. LV is mildly hypoplastic, not quite apex forming. And we actually were hopeful that this might be biventricular, but unfortunately did not do well with hybrid physiology, and actually has gone down a single ventricular, univentricular pathway. And then an example of an unbalanced AVSD, where you can see an ASD primum, a common AV valve, atrial septum lines up with a ventricular septum, and there's a very small portion directed to the LV cavity, and with color flow, it was minimal flow entering that LV. Moving on to some other versions of univentricular hearts. Here is an example of a tricuspid atresia, an LA, mitral valve, mildly dilated LV. There's a sense here, I'm sorry, I know this is a little dark, of the septum here and a small cavity over here on the right. When we tip up a little bit into the LV outflow tract, you see this small VSD and a hypoplastic right ventricular chamber. I like this view when you're looking at a hypoplastic anterior chamber. This is actually an apical 3-chamber view. I'm sorry, it's a little bit off axis, so it's mitral valve, LV aortic valve, nice continuity between the mitral and the aortic valve. And you see this small VSD and this little anterior right ventricular chamber. And looking with short axis, this is really all there is of a right ventricle in this patient. Here's the VSD, right ventricular outflow tract, and the pulmonary valve. Again, just to briefly point out that for many of our functionally univentricular hearts, you have to have a good sized atrial communication because you have to have a way to get both systemic and pulmonary venous return to the dominant ventricle. So here, this is just showing you a large ASD with unobstructed right to left atrial shunt. Again, we were sort of worried about that VSD, and this is normally related, so we'd worry about pulmonary blood flow. So here's a view of the aortic arch. It's probably hard to see, but there is a small reverse-oriented duct, which makes you think of limited pulmonary blood flow in utero. And there was a hypoplastic pulmonary valve. So this child actually went on to have a BTT shunt. Looking at another variation of tricuspid atresia, again, LV, mitral valve, LV, but in this case, we already can see the hypoplastic right ventricular chamber. Again, I'd like to point out the atrial septum is bowing into the left atrium from the right to left atrial shunt. Looking at a short axis, we can see the LV. What I liked about this one, that this is clearly a mitral valve, so we know we're dealing with an LV. And then we want to look at the great vessels. There's one large one small one. Hopefully I can convince you that this is the PA. It's diving posteriorly, it's bifurcating, and this thread bouncing around the LA is actually, again, the atrial septum that's being pushed over because of the right to left atrial shunt. So when you have two discrepant great vessels, then you can certainly go, what I like to do is go look at the arch. So if the arch is small, then the small one is the aorta. In this case, the aortic arch is very hypoplastic and tortuous. It's easier to see with color. Here's the arch as we go around, hypoplastic transverse, severe coarc, large duct. So the PDA here is supplying systemic output. So again, in transposed great vessels and tricuspid atresia, you would expect arch issues. Moving on to a different example of a hypoplastic right heart. See the LA, mitral valve, LV. See this small RV with marked hypertrophy and what looks like a moving tricuspid valve leaflets. So just to prove that it is actually a patent tricuspid valve and not imperforate, we see that there is a small antegrade jet in diastole across the tricuspid valve. And then we look in short axis. Here is your LV and here is your hypoplastic RV anteriorly and rightward. So now we want to go looking for a pulmonary valve. And this is what was measured as the pulmonary valve. I know it's a little fuzzy. It's actually a blown up parasternal short axis view. So here is the aortic valve, here is the LA, the RA is over here, and here was tissue bouncing back and forth that we thought was a pulmonary valve. However, when we put color on that area, what we see is two-fro flow. And when you Doppler it, what you see is the two-fro flow of a left atrial appendage. And this is unfortunately, easy mistake to make, or at least I've made it twice, and I actually did not read this one, and the person read this also. So what you're actually looking at here is the tip of the left atrial appendage with a little bit of fluid around it. It's also, you can see it here more clearly, that it was easier to see the tip of the left atrial appendage here. But because we always go looking for a pulmonary valve here, that's where the appendage lives. So, and you can get fooled because we don't expect antegrade flow. And because this child has pulmonary atresia, we need a duct to supply blood flow to the branch pulmonary artery. So here's a large duct feeding good-sized branch pulmonary arteries. Moving on to double inlet left ventricle. This one will be a classical one. It actually is interesting. In our database, we have more Holmes hearts than the classical double inlet left ventricle in the last 10 years. So that's why these pictures are a little bit fuzzy and old. So two AV valves draining into one large ventricle. I like this view because this is a short axis of the two AV valves. I was taught to refer to the AV valves as right-sided and left-sided because they don't have necessarily the typical appearance. But in this case, this posterior AV valve certainly looks like a mitral valve to me, and the anterior one looks like a tricuspid valve. When we go to our parasternal long axis view, sorry, my mouse is unhappy with me. There we go. Parasternal long axis view, you see this VSD and this anterior ventricle. We can't tell yet which semilunar valve this is. We tipped up into the anterior right vessel here, which is hypoplastic. It doesn't bifurcate, so this is the aorta. So this is the aorta coming off of the hypoplastic RV chamber, and we can see the small VSD here. So this is discordant VA connections. I'm just going to let this play once so you can see large pulmonary valve, small anterior aortic valve. And so I took snapshots to sort of point this out. So posteriorly, here we have the pulmonary valve. We sweep a little more anteriorly. I know it's hard to see, but that is your aortic valve. And you're starting to get into the VSD. Here I've frozen it just because I think this is a helpful view, for at least for me, for pattern recognition. Here is the bar of the septum. It typically in the double inlet left ventricles has this horizontal course. Here's the VSD. And if we go all the way anteriorly, and again, you will not see this chamber unless you sweep all the way anteriorly till you've essentially lost the heart. You can see here is the septum. So here you can clearly see the more inferior LV and then the more anteriorly, superiorly anterior RV, which we classically see in double inlet. And just to verify, given that we had a small VSD and small aortic valve, again, severely hypoplastic aortic arch, ductal dependent for systemic blood flow. Moving on to another type of double inlet left ventricle. Again, in this view, they look fairly similar. I neglected to mention both examples that I'm showing have two good-sized AV valves. This is the one exception to the rule where you don't necessarily need an ASD as long as neither of the AV valves are obstructed, because both systemic venous return will go to the LV and pulmonary venous return will go to the LV. But when you go to the short axis view, you get a completely normal looking short axis view. So this is your aortic valve, this is your pulmonary valve. If you look, there even a suggestion by 2D of coronaries. Both semilunar valves are good size. This anterior one bifurcates, so that's a PA. The only thing that's missing is the tricuspid valve, and this is where it should sit in a normal heart. So again, to show you this one, as a sweep, this sweep starts right below the aortic valve, so this would be your anterior RV, and as you watch, this anterior AV valve has attachments to the crest of the septum, and as we watch it come all the way down, sometimes it's hard to tell whether you're dealing with a papillary muscle in these dominant ventricles versus a septum. So what I do is I want to follow it to see if it ever completes the wall. And so in this case, I'll let that play again. You can see that this bar comes all the way across and shows you this is your LV, this is your anterior RV. But as you watch, this AV valve is 100, there are no attachments to the RV at all. So this would be a double inlet left ventricle, normally related great vessels, otherwise known as a Holmes heart. Okay. And as expected, this child actually had good-sized aorta. The aortic valve was good-sized, and good-sized PAs. This was done on the first day of life, which is why there was still a duct. When the duct closed, after a couple of weeks, the infant was overcirculated and actually got a PA band. And then this is one last one quickly. I believe that Dr. Weinberg showed this one for her unbalanced AVSD. It looks like the same pictures that I've been looking at. So here is the apical four-chamber view. Just so that people don't confuse, this is a very dilated coronary sinus because there's a left SVC. You can see the atrial septum. You can see what looks like an ASD primum, which is why we think that this is an unbalanced AVSD. You see ventricular wall as we go all the way around. But there's a little bit of extra stuff here. Again, when you're looking for two AV valves, two semilunar valves, two ventricles, you want to make sure you do a sweep all the way from posterior to anterior. You want to start before the heart and end before the heart. And so as we watch, we're only going to see one AV valve. And then if we watch over here, you'll see a large semilunar valve, which is the pulmonary valve, and then you'll see a hypoplastic ascending aorta. Again, short axis view looks very similar to what we actually saw with the mitral and aortic atresia. No obvious other ventricle, a very hypoplastic ascending aorta. And then the short axis view, since us imagers frequently will use the AV valve to determine a ventricle. We had some discussion about this. I've looked at it multiple times. It doesn't look to me like a tricuspid valve. It doesn't look to me like a mitral valve. It looks most like an AVSD, but still it's sort of got 4 leaflets. So it doesn't really look like an AVSD to me either. But that's also, the AV valves frequently are not that easily identifiable once you're in the univentricular heart. And just for clarification, this is the left SVC coming down and around and entering the coronary sinus. This is an extra tissue over there. And to be expected, this showed a hypoplastic arch. I think that this is the same heart that Dr. Weinberg showed with the red flow going backwards in utero. We were using the same database. So ultimately, I diagnosed this. I did actually read the first ex utero echo, right dominant, unbalanced AVSD, mostly because of that primum ASD, double outlet, right ventricle with aortic atresia. We only had one recognizable ventricle, although I think that there's that tissue that we can see in that 4-chamber view. Hypoplastic aortic arch. I didn't show you, but this infant also has bilateral SVCs, ipsilateral pulmonary veins. I actually forgot to put in the interrupted IVC, and so this child classified as left atrial isomerism, and I believe that the next speaker is going to show some additional imaging that we obtained. Thank you. It's my pleasure to introduce Dr. Laura Oliveri, who is very active in our imaging world here at CHP. She is the Director of Non-Invasive Cardiac Imaging, so does both echo and cross-sectional imaging. Thank you.
Thank you, Libby. Good morning, everybody. Thanks so much to the organizers for asking me to speak. I love being described as active in imaging. That's like my goal in life, so thank you. I guess what I really, as I embark on this talk on cross-sectional imaging, this is what we're going to cover. We're going to cover kind of the general goals of imaging, talk a little bit about like what's imaging for surveillance versus what is imaging for like diagnosis and management. We'll go through the modalities, the cross-sectional modalities, MR and CT. We'll go through a few cases. So in terms of our goals, I think it's just important to say, particularly after the outstanding talks by Drs. Weinberg and Lamford, that echo is just the mainstay of any diagnostic imaging in order to sort out what kind of heart we're dealing with, and echo is the mainstay of any surveillance imaging, i.e., looking for changes over time. So although I am tasked with talking about cross-sectional imaging in univentricular hearts in stage 1, I guess the main thing is like, I think we can we can sort out most of this by echo, but there are a few key areas where I think cross-sectional can play a role. So when you think about imaging prior to stage 1, again, between a clinical exam and a great echocardiogram, really there are very few mysteries to be solved, but there are a couple ways, specifically CT can be useful. Sometimes a CT can be more helpful than like the 4th limited echo to find the right upper pulmonary vein. Sometimes you have to pull the trigger on cross-sectional, or for arch anatomy, or sometimes for coronary anatomy, although this is a little bit of a fraught question in a newborn who might only weigh 2 or 2.5 kilos. This is an example of such a CT image. This is actually the CT image of the fetus Dr. Weinberg showed and the baby that Dr. Lamford showed, which demonstrates here clearly, confirms the ipsilateral pulmonary vein anatomy. We'll look at this in more detail later. And then the other place where cross-sectional imaging prior to stage 1 can be helpful, I think, is when we're considering managing these children using ductal stenting. Not every kid, obviously, this isn't the right choice for every child. And for sure, the kids who have ductal dependent systemic blood flow, their ducti are pretty vanilla, like they're just tend to be straight shots. And I don't know that they need additional characterization of those ducts. However, just like Dr. Weinberg and Lamford presented, the ducti associated with pulmonary atresia, pulmonary stenosis, and ductal dependent pulmonary blood flow, they can be wacko and wild and take all sorts of curves. And each of us imagers has like a cute word we like to use to describe them. But in essence, if Dr. Kreutzer is going to go stent that duct, I think she and her colleagues would prefer us to characterize it a little bit more. And so that's when CT can come in helpful to understand the curves and the insertion points and what, if the PAs may or may not become discontinuous after you turn the prostaglandin off. It might change their approach and their strategy. This is definitely a place where CT and cross-sectional can help out a little bit more. So now that's kind of pre-stage 1 or pre-whatever first management strategy these children are going to have. Now let's think about the interstage where they've gone through their initial palliation, but we're in the single ventricle pathway, so we've got more stages coming. So, and a lot of people like to call this the interstage. So no matter how you got in there, cross-sectional imaging definitely has a spot here, I think. Again, echo is the mainstay. Echo is definitely used for surveillance. The every 2-week echoes and the stage 1s are important for us to understand and surveil for anatomic changes. Secundum atrial septal defects close over time, arches remodel over time. So echo is really important to understand how these babies progress between stage 1 and stage 2. But cardiac MR, I think here, this is where it's the time to shine for cardiac MR. It can be used, it is used in multiple institutions and can be used to kind of non-invasively assess risk before stage 2 in the interstage program, or in the interstage time period. So maybe we can delve a little deeper into cardiac MR. We'll talk a little bit about strengths and limitations. A lot of what I'm gonna say has been, actually was just published this year in this beautiful paper, just talking about congenital cardiac MR. So cardiac MR obviously does not involve ionizing radiation. You can actually get decent images in some children without contrast, although contrast helps with signal to noise ratio. It can provide anatomic details, and usually those of us who do this in babies and kids, roughly the age of interstage kids, we push the resolution down to around 1 millimeter isotropic, which takes a little bit more time, but definitely gives beautiful results. And then if you do this and tailor the exam to the child, one can easily get reliable information regarding QPQS, valve regurgitation, and then my favorite thing, pulmonary artery flow splits. We can tell you exactly how much blood goes to the right lung and the left lung using cardiac MR. In addition to this, you can obtain RV and LV volumes. This is important, I think, for those kids who are a bit borderline, I guess, in the hypoplastic left heart complex, where maybe you're wondering, is this, or I guess either side, the RV or the LV, where you're kind of wondering, all right, is this LV going to engage and grow? Are we going to be able to use this LV eventually or RV eventually? Measurement of volumes is validated and reproducible in this population with MR. Obviously function, and essentially can measure flow in any, maybe not any thoracic vessel, but any major thoracic vessel, and forward and reverse flow for any valve. So these are things you can ask your imagers to get for you in these babies. The limitations of MR, you can't, what I am citing as resolution with today's scanners and equipment, you can't really go beyond that. So that is, I think, adequate to diagnose this population, but there's no, at this time, with the technology of today, there's no further kind of resolution that we can get there. These scans tend to take a longer time, and they basically require sedation, sometimes general anesthesia, depending on your scanner and your approach. And then the presence of metal, if there's any metal in the chest, like a stent in the duct, you can kind of, this further degrades the signal that you're already kind of trying to squeeze every bit of signal out of these kids. MRIs. And so this is an example of a hybrid stage 1 where you can see here, this I guess would be in the hypoplastic left heart complex where there is antegrade flow out the ascending aorta. This is the pulmonary artery. There's plenty of flow down the descending aorta. And what's missing here is the ductus arteriosus because there's a stent in it. And then this is just an example of contrast-enhanced angiography. This is in a patient who already went through a stage 2. I just want to point out with MR, you can easily see the glen and the branch pulmonary artery. This isn't CT, this is MR. And then just one more note about MR and flow. This is an example. This is about a 4.5 kilo baby that can see has hypoplastic left heart syndrome. And has been palliated with a Norwood arch reconstruction and then a Blalock-Taussig Thomas shunt. So for sure, 4D flow is a nice tool, I think, for visualizing the hemodynamics of these children. And in this case, I think we pretty clearly identified some flow acceleration at the aortic isthmus, concerning for a coarctation. I'll just take a moment and mention, even though beyond stage 2, between stage 2 and 3, which is a little bit out of scope of this talk, there's like great evidence and most of, for being able to measure the burden of aortopulmonary collaterals. Using cardiac MR, there's really no other way to do this, so I would consider this unique information and a unique indication to obtain cardiac MR in these patients. These are all the these are all the equations that we reference and all the measurements that we use, but essentially it's a reliable way to measure this and can be a useful and unique component of the care of these children. So it's kind of MR. Maybe we'll pop over to CT now and talk about its strengths and limitations. I think we know you can get unbelievable 3D anatomic details using CT, and that's mainly due to the spatial resolution of these scans. It's about twice as resolved. The imaging acquisition is really fast. And actually, a lot of times when we do this, it can be so fast that some babies don't always need sedation. We can kind of feed them and swaddle them up and image them while they're asleep, depending on the indication in the baby. And this is called a feed and bundle technique, which many institutions utilize in this population. It's kind of nice to avoid sedation in this like higher risk population. Although when you need sedation, it's nice to have a cardiac anesthesia service to safely sedate the children when we do need it. And then CTH strengths, obviously we can get linear measurements for any vessel in the body. We can measure it, we can see it and measure it. And then there's this additional component, since so many of our children don't just have heart disease, they have definitely heart and lung disease, and then can also have other anatomic issues within their thorax that are like clinically very important. It's a bit of a one-stop shop if you need to see the lungs and do a CTA or understand the relationship between airway and a vascular plug or something like this. CT is a great modality for those types of questions. The limitations are that ionizing radiation is required, contrast is required. And if we need to do a study that is gated to cardiac motion, i.e. we only acquire little bits of the image every heartbeat when the heart is still and in the diastolic phase, that's what cardiac gating is, then this definitely requires a breath hold, probably requires a heart rate lowering strategy, and definitely requires, like, it's a bit heavy-handed. You need general anesthesia, you need a low heart rate, you need everything fairly well controlled in order to do that imaging. So it's kind of an overview of how cross-sectional imaging can help us manage these patients. I like what Dr. Weinberg said earlier. I think it's more than just getting pretty pictures to ooh and ah at. I think of it as imaging to help manage. So anyway, we'll go through a few cases. This is a baby. This is the further imaging of the baby with hypoplastic left heart complex, I guess. And it turns out to have heterotaxy and multiple venous anomalies. So here we can see coming up, this is anterior, this is posterior, this is left, and this is right. So coming up inferiorly, can see hepatics join the base of this right atrium here. This over here, this is the descending aorta. This is the interrupted IVC with hemiazygous continuation. This dark spot is not a clot. That's the left superior vena cava. This baby had an injection in the right arm, and the left arm veins are dark, whereas the right arm veins are light. I think the value of this scan was to confirm what Dr. Lanford suspected by echo, which is that the right veins insert into the right atrium and the left veins insert into the left atrium. So this baby definitely had ipsilateral veins, pulmonary veins. This is the same data set that, again, the beauty of 3D imaging is you can slice and dice it any way you want to look at it. So if you prefer a coronal plane, go for it. I'm an axial plane type of person. But this is kind of the beauty of 3D data. We can visualize it any way we want, and including in 3D. So this is that same data set, just with a 3D reconstruction that you can kind of spin in space. Just a note on this, a 3D data set is only 3D if you keep it moving. When you pause it, it just becomes another 2D data set, and it's difficult to resolve differences. But if you keep moving it, that's when the 3D depth details come in, and that's, I think, when the real value is added. So that's our first case demonstrating how CT was actually useful in the pre-stage 1 assessment of this baby, of a baby. This is now an example of how cross-sectional imaging can be useful in the interstage period after stage 2. So this is an example of a baby who is a Glenn, who had increasing cyanosis, maybe some coexistent lung disease, maybe some other medical issues, but mainly trying to understand if we could kind of non-invasively add value to understanding why this baby may or may not be blue. So the panel on the left is a 4D flow image acquired with cardiac MR. This is using an IV contrast agent called ferrimoxetol, which really helps boost signal to noise. And I think we can all recognize here, this is the Glenn. So the SVC coming down to the RPA and LPA looks wide open and beautiful. And then over here, we can easily recognize the aortic arch. And this is in that arch view, the left atrium, right atrium. And I think our eye, all of us, this is catching our eye here. There's kind of this flame billowing around in the right atrium that makes us imagers anyway suspicious. Oh, I wonder if there's a restrictive atrial septum. And here is that same data set. Instead of one specific slice, it's just the whole, looking at the entire chest in the anterior posterior view. And you can see clearly our suspicion was correct. There is definitely a restrictive atrial septum for this baby. So they went and had that addressed in the cath lab. Last case is a neonate with pulmonary effusion, intact septum. This is the imaging I showed you previously, where we have this S-shaped ductus and these PAs that look like, for all the world, if you turned off the prostaglandin, they would become discontinuous. Very technically difficult baby to manage, but was managed with a ductal stent. So here's the initial angiogram that shows this left arch, left ductus, and then kind of simmering LPA stenosis that had a successful both ductal stenting as well as LPA stenting with a beautiful result at the end. Echo surveillance was obtained for this baby, and this is examples. Again, you can see here the arch, the stent, and then this continuous flow through the ductus arteriosus into the RPA. And LPA was always a little bit difficult to see. Here's about a month after the procedure. Again, you can see the ductus arteriosus with the stent inside, as well as the stent extending into the right pulmonary artery. Flows coming down the ductus, flows definitely taking a right and going to the right pulmonary artery. It's just hard to say what's going on with the left pulmonary artery, and I think this is a common place to be in. Stents make imaging very difficult. So this baby had a CTA. You can see here's the stent material, here's the left pulmonary artery. And I guess while there is variation amongst scanner manufacturers and scanning techniques to kind of minimize metal artifact, stents also kind of disrupt and disturb CT imaging as well. Ultimately, this baby ended up going to the cardiac catheterization lab where a severe left pulmonary proximal LPA stenosis was diagnosed in the cath lab. and managed, and the baby clinically improved. So just demonstrating that cross-sectional imaging is good, but for sure, if there's particularly a stage 1 baby who's not doing well, invasive imaging is usually very helpful. So in conclusion, just want to leave you all very confident that echo is the mainstay of imaging in the single ventricle prior to all stages and in all interstages. Echo's exceptionally useful. Cardiac MR can add value in that we can understand and visualize 3D anatomy as well as some reliable hemodynamics, not pressure measurements, but definitely flow measurements. And CT adds value with extremely high resolution anatomy. But remember, we don't get any physiology from CT. So if I see a small pulmonary vein, I have no idea what the gradient is in that vein and if that stenosis is important or not. So it's typically most helpful when coupled with some other imaging modality that incorporates time, so MR or echo. And then finally, I think we all tailor our imaging approach in these babies to what our institution has invested in terms of the expertise that has been recruited there, as well as the equipment that's there. And so anything I've pointed out today is just a broad spectrum of possibilities, and this tends to be institutionally driven. And invasive cardiac cath is warranted in any interstage patients who are clinically unwell. Imaging can be helpful, but I think cath gets less work. Thanks so much for your attention. I think now thank you. I think now I would like to invite Dr. Tariq Al-Said up to lead us in a question and answer session. Dr. Al-Said is one of our brilliant core imagers here at Pittsburgh. He does exceptional echo, cardiac MR, and cardiac CT imaging. So thanks, Tariq.
Thank you very much. Thank you very much, Laura, and thank you very much, Jackie and Libby. This was such an incredible session, really great talks. So we have few questions coming through the chat. So one question from Dr. Arapa was asking Dr. Weinberg, what are some of the measures that you can do to prevent prematurity in this population?
Sure. So when we diagnose significant congenital heart disease, and especially with these functionally univentricular hearts, that is always the question about when is optimal timing for delivery and how we sort of optimize that and try to avoid prematurity. We know that for these babies, adding in prematurity and the differences that we have in their lung development and their brain development significantly, that those are all challenges in the long term, both for the initial surgical palliations, but also in their long-term prognosis. So we know from a lot of data that's out there that avoiding prematurity is best for these babies, and that is often a challenge because when the obstetricians know that there's a fetal issue, that can make things harder to monitor during the pregnancy and makes them more nervous too. We understand, but we work really closely with our MFM colleagues, our high-risk obstetricians, and this question very frequently does come up. We often are discussing the babies as far as what optimal monitoring strategies are, whether it's monitoring of fetal heart rates with NSTs, monitoring of fetal well-being with ultrasound assessment from their standpoint as well. And we encourage them to not deliver prior to 39 weeks gestation when at all possible. Of course, that has to be sort of countered by assessments, making sure that the baby is growing in the intrauterine environment. Intrauterine growth restriction can be a big problem. We know it's more common with congenital heart lesions, especially severe ones like our univentricular hearts. And in a lot of times there is question about whether that fetal placental environment is worse for the baby than having them in the outside world. And so it's usually a very intimate, close relationship with us and the MFMs and lots of discussion, but trying to encourage them to deliver later. And avoiding use of just the growth parameters, but looking at the overall fetal well-being before deciding when to deliver. So it takes a lot of communication.
Thank you, Dr. Weinberg. I have another question from Dr. Tan to Dr. Lamford. For functional univentricular heart, what echo parameters do you prefer to assess function in these patients?
Oh, that's a challenge. Depends on which ventricle we're talking about. The LV, we still use standard LV measures. Although I think, as we saw, the LV does tend to be dilated when it's the dominant left ventricle. So for that, we still, if you can get a good short axis, you can do a shortening fraction and then the apical floor chamber. And we also use bullet method sometimes since there are normals for pediatrics, we use the bullet method if you can get a good parasternal short axis. RV is a challenge. So a lot of qualitative. We do measure TAPSE, RV fractional area change. I try in my head, and 3D will help us with this, certainly, put together the images from an apical 4. I think you get the TAPSE and the RV fractional area change, but then the question is the RVOT. So in my head, I sort of try to add them up. If one looks down and the other looks good, then you might get a mild RV dysfunction, but it's very difficult to be truly quantitative in a single dominant RVs. I echo.
Excellent.
We get MRIs when they're older.
Excellent. Thank you, Dr. Lamford. Speaking of MRIs to evaluate ventricular size and function, there is a question from Dr. Natarajan about ventricular volumes or other indices in borderline left ventricle and how you use that.
Yeah, that's a great question. And it's a question that, so the answer is that there is, I think every year that goes by, there's more and more evidence to suggest that cardiac MR is exceptionally useful in answering this question. Mm-hmm. The group in Toronto, the group in Boston, and other groups around specifically have published on this. And it's really interesting, every time a publication comes out, and I know you know this, Tarek, too, it seems like the threshold for what is considered an acceptable LV seems to keep creeping down. I think it started somewhere in the 50s. I think it's in the 30s now, based on the different institutional experiences. But I think the upshot here is that cardiac MR is a tool that can be helpful in this case. It is very important that the cardiac MR is performed and interpreted by a lab that's comfortable doing this and takes all of the little, manages all the little details of the acquisition appropriately in order to get the best data out of it. But the upshot is that yes, cardiac MR can be very, very helpful to answer that question.
Thank you.
Still need to evaluate the valves. So just, which is best done with echo. So just in terms of size, yes, MR.
Do you want to address the issue of EFE? Because sometimes you can have a normal LV volume.
Yeah.
But in the example that I showed, I think that there was probably much more EFE than we realized by echo, severe LV diastolic dysfunction.
Yeah, so that's another great, and I just have to recommend to anyone listening that I think I'm trying to remember the first authors' names, but they've done beautiful, a few from Toronto that have really tackled this exceptionally in an exceptional and systematic way. So for sure, EFE on echo, the corollary on MR is late enhancement. So for sure, like extensive late enhancement, even with a normal-ish LV volume, yeah, that's not going to be a successful 2V strategy. And same thing for an LV volume that's normal, but the mitral valve is like thick with shortened chordae and a huge inflow gradient. That might not be successful either. So to your point, yeah, the fibrosis matters. I don't know that anyone knows precisely how much fibrosis is enough or is tolerable. I think those questions are still out there, and they're exceptionally hard to answer because fibrosis seems to be like a binary, it's like present or absent, rather than being quantitative in these little babies at this point. But your point is well made.
Thank you. Another question about like prenatal counseling for these families. So a lot of times these single ventricle patients can have a lot of other medical problems and can have very complex anatomy. So at what point would you start talking more about like, palliative care or, like that intervention may not, improve the quality of life or the duration of life for these patients?
Yeah, that's a really important question. I think that the short answer is that we could always be talking about that more. And I think that any fetus that we're counseling a family about a functional univentricular heart who we expect to require surgical staged palliation rather than any possibility of a two ventricular repair, we know that that course is going to be long and that there's going to be complications. And we also know that some of those cases are more straightforward. In some of the examples that we showed today, both prenatally and postnatally, there are times when that's more straightforward and there's times when it's less straightforward and more complex. The patient that we all showed examples of that has complex venous anatomy is one example where surgical palliation we expect to be more complicated. The other fetal patient that I showed that had poor right ventricular function, we would also expect may have a more rocky course than others. And so those are in particular the cases that we more strongly than others recommend a prenatal consultation with our palliative care, we call it supportive care team here. And they actually can start to introduce those ideas with us to the family about both understanding what the course will look like, what the complications may be down the line, should they go through with a surgical palliation. But in some cases, we do try and bring up the option of comfort care with all of these patients. But again, in some, it's more of a focus of our conversation than others. In a lot of places, we know that we can perform surgical palliation for these babies, but it is recognized that that does not create a two ventricular circulation, and that I do express to families that will have long-term consequences and limitations. And so helping families understand the situation and the expected course is the first step. And I think it is important to offer them options, which can include comfort measures without surgical palliation in some cases. It's a tricky conversation to have sometimes, but I think it's important for sure.
Fantastic. Thank you very much. I think we all agree this was a fantastic session, so let's give the speakers another round of applause. And then at the end, we will have a panel discussion. So stay with us. We will have more discussion at the end of all the sessions. So to stay on time, I'm going to introduce our next speaker, Dr. Joan Sanchez de Toledo. He is an associate professor here at the University of Pittsburgh in both cardiology and critical care. Also, he is an associate professor at University of Barcelona and the department chair at the Hospital Sant Joan de Déu in Barcelona and the director of the Heart Institute there as well. So welcome, Joan.
Thank you. Thank you very much for the kind introduction.
Please turn your microphone on, doctor.
You may still be muted, Dr. Joan.
Can you hear me now?
We can hear you now.
That's perfect.
Perfect. I was saying that thank you very much for the kind introductions. And I will now share my screen, and please bear with me and just make sure that we all see the same presentation. Let me know if...
We see PowerPoint, just go into presentation mode.
Perfect.
Perfect.
Thank you very much. Unfortunately, I'm not here with you to enjoy this fantastic session. I am currently in Barcelona, and I'll try to go in the next 20 minutes through a difficult topic, which is the postoperative or the critical management of these patients. I have to cover from the preoperative to the postoperative issues of a very complex group of patients, and it might be too short of a lecture, and I'll be happy to discuss some issues after we finish. This is a complex slide, just to say that I have no disclosures, but the main one that I have, that I think it's important to disclose, is that I am now in Europe speaking to a North American conference about a very complex group of patients that traditionally have been treated very differently, both sides of the ocean. And I'm speaking about Europe because I'm European and I don't want to go any other place. Once this man, Robert Kagan, said that Americans are from Mars and Europeans from Venus, that they agree on little and understand one another less and less. So now I try to think, what am I exactly? I don't know if I'm European and American, and sometimes that's important because I don't know if I agree with one or the other or none of them. But when it comes to treating hypoplastic left heart syndrome, I think it's very, very important to understand where we are treating those patients and what is our environment, what are our cultural backgrounds, religion backgrounds, and what are the resources that will apply to that precise place that we want to manage those patients. As a general definition, I think that we have to focus on what we are going to do. We're going to describe management of a wide group of patients with similar anatomy and similar physiology, that on top of that, they have a lot of non-cardiac anomalies. And there's something very, very important. Whatever I'm going to say applies to patients that will end up going to one single pathway. I'll let you know why I'm saying that in the later slides. So the most important thing is to understand that, again, this is a rare disease. And by rare means that there is not a lot of centers that they do a great volume of those operations, that they associate high morbidity and high mortality, and that there is a lot of long-term consequences, not just to the patients, but also to the families, the society itself, and the whole healthcare system. Here on the right side, you could see the amount of expenditure related to each of the most common procedures, and you would see that the cost for a given Norwood operations overtake the rest of the operations by a significant increase. This is important, right? We said that this is a rare disease with a high morbidity and high mortality, but those are the raw numbers and the very striking numbers. Mortality based on STS, the North American data of the Norwood operation is as high as 14%. Same operation reported by the European Association is up to 22.8%. And as I said, that sometimes Mars is Mars and Venus is Venus. Within the hypoplastic left heart syndrome, the Europeans include biventricular repair as a surgical option, so nothing else to disclose. So some important facts, and you all know that. Prenatal diagnosis influence the prognosis. We know that protocolized pre- and post-surgical management also influence the prognosis. And we have been repeating over and over again that we need interdisciplinary and multidisciplinary management for those patients. Probably one of the most important things that we have to cover is how the prenatal diagnosis influence the postnatal risk to move forward with these procedures. And we know that there is certain preoperative risks, that being said, prematurity, low birth, having genetic abnormalities, and others such as having a sick patient intubated prior to surgery that will influence greatly the prognosis of these patients. And then, as you've seen in previous imaging discussions, there is precise anatomic variations and some findings in the anatomy and the imaging studies that will preclude for a bad prognosis. And before moving forward with management, it's important to understand that there's options. And the only option is not the surgical palliative path, but also there's other options that involve the termination of pregnancy, the postnatal palliative care, and I would say that less and less quoted in the literature, heart transplant is probably not considered now as an option from the get-go on those patients. But it's important to highlight that it's okay if people want to terminate the pregnancy. It's okay if postnatal palliative care is considered among the decisions that the family is willing to take for this patient. And this is one of the largest series that was studied at the beginning of this century that study the outcome of prenatally diagnosed hypoplastic left heart syndrome. And if you see in the left side of the screen that the outcome, if you compare to the amount of patients that are diagnosed and cover the amount of termination of pregnancies related to the diagnosis of a hypoplastic left heart syndrome. Over time, we have been able to change and to obtain a cultural change, and there's more people prone to go to the surgical palliation path. And you see that over time, since 1995 to 2012, there's more and more surgeries performed to those patients that once were considered not suitable for a repair. And of course, when we talk about management, we have to have clear some important concepts. We will need to stabilize the patient. We will need to allow time to get a precise anatomic and a physiologic description. We will need time to rule out other non-cardiac malformations. And then from the get-go, we have to invest on family education. We need to ensure that the patient, but also that our families are comfortable and that they understand that that's going to be a long path. And then understand physiology. And there's some concepts that it's important to have clear before treating those patients. We need to understand what QPQS means, the effects of pulmonary overcirculation on the end diastolic volumes and pressures of the right ventricle, how those things will affect the coronary perfusion and the systolic function of this solo right ventricle that will pump two circulations. Probably the most important thing, and it's not time now to spend with physiology descriptions about the importance of the Fick principle, but this is probably the most important equation when we try to teach during rounds about a pre and postoperative management of the single ventricle physiology. That being said, this equation has a lot of problems and can mislead us a lot. So in the ideal world, we always look for a balanced circulation, QPQS of 1, but that's never the case. And not just that's never the case, but a bad interpretation of our data will mislead us to make assumptions that do not apply to our patient. Understanding that this is an equation that has a lot of false numbers and hidden numbers might help us understand that it's very difficult to relate and translate this equation to the clinical bedside. And what I'm trying to say is that since we don't know the real number of the pulmonary vein saturations and that we don't know exact numbers of the mixed venous saturation, the equation can change and could mislead us a lot. So the main goals for management of these patients preoperatively are summarized in this slide, but essentially we have to ensure systemic circulation. We need to minimize pulmonary overcirculation. We need to make sure that the patient is comfortable, that we save some venous access for what is coming in the future. And then we have to be diligent assessing and protecting the function of all the organs. So in summary, what we need to do in order to prevent for early pulmonary overcirculation is play with our pulmonary vascular resistances, try to increase PVR, try to support function of the heart, decreasing afterload, decreasing systemic vascular resistance, and trying to unload the heart with early initiation of diuretics. There's a lot of discussions of how to manipulate PVR in the preoperative setting. What's clear is that there's only two strategies. One is by positive pressure, and the other one is by inhaling a gas. Whereas hypoxic mixture of CO2, that's another question. The effects of positive pressure are clear, and we need to go back to the physiology to understand how the relation progress between the increased volumes of the lungs and the increased PVR and the decreased volume of the lungs at electrolysis with increased PVR. So what we try to do in the preoperative management is put those patients on a little bit of positive pressure, non-invasive ventilations, high-flow nasal cannula, CPAP, to try to achieve a little bit of overdistension to increase the pulmonary vascular resistance. Much has been written about the effects of CO2 and hypoxic gas mixture on those patients. Albeit the initial reports from Dr. Tabot, also Gil Bernowski, were not that keen about the use of hypoxic mixture. We now know that the effects of hypoxic pulmonary vasoconstriction in the lungs will benefit those patients preoperatively. Those are the initial papers from Sarah Tabot and also Gil Bernowski, trying to make the case where CO2 or hypoxic mixture was better for those patients preoperatively. If we go down and we dig in the data of these papers, the conclusions are not clear. And the conclusions that apply in 2001 probably do not apply on these ones, on the current era. This slide is important just for you to understand that when we talk about the effects of hypoxia, we have to always keep in mind that hypoxia will be artifact by acidosis. If we have a given PaO2, but on top of the PaO2, we have a patient that is severely acidotic, the effects on the PVR will increase dramatically. So yeah, we have to control the oxygen, and we could achieve hypoxic mixture, but we have to always keep in mind that these patients should be on a very control level of pH. There's many publications now that support the use or that could support the use of hypoxic mixture in the preoperative setting. But as I said before, this is not the case, and this is now outside of the scope of this talk. As a rule of thumb, at least what we do here in Pittsburgh, to make sure that these patients get to the operating room in a relatively stable condition, is a protocol that was described a long time ago by a very well-known colleague of us that described the use of milrinone, the combination of milrinone, high flow nasal cannula, hypoxic mixture, and early initiation of diuretics in all of the patients that were going to the Norwood operation. What happens in the postoperative period? So the postoperative period is exactly the same. We need to ensure circulation, we need to minimize overcirculation, and we need to assess and protect multi-organ function. Provide comfort to the patients, safe venous access, and make sure that we give and we start to provide good nutrition to those patients. Probably something that is very important is to understand what, who, how, and when is going to do, and when we're going to do the operation. The what is very important. Are we going to do a Norwood BT Shan? Are we going to do a Norwood Sano? Are we going to do a hybrid? Who is going to do it is very important, but it's also outside of the scope of this talk. We always want the best to do it, no matter sex, country, place. There is always a good surgeon that could do the best surgery. But then it's important to understand the details, the intraoperative details. Are we going to do deep hypothermic cardiac arrest? Are we going to do cerebral anterograde perfusion? How long is going to be the rest? All those things will matter and will translate to the postoperative period. And then the when. Are we going to do an early Norwood? Are we going to do a late Norwood? This is a paper, a provocative paper from Gil Bernosky, the group of Children's National, that now they are advocating to postpone the Norwood procedure to a later stage. Whether they are right or not, there is just we just need time to know it. This is the summary of what we do. Hypoplastic left heart syndrome can go to either the stage 1 BT Shan or RB to PA conduit. Once we said that it was related to morphology, but probably now is more related to an institutional approach. And then there is some particular cases, the high-risk cases that are associated with comorbidities, low weight, etc., that they should go straight to the hybrid approach and try to prevent for the surgical morbidity and to displace the surgical morbidity to a later stage. This is a slide that tries to summarize the effects, the physiologic effects of the three main surgeries of these patients. So if we do a Norwood BT Shan, the impact on QPQS, it's going to be significantly higher than the one that will have a Norwood operation with an RB to PA conduit, or also the one that the hybrid approach will have. The BT Shan will have an increased pulmonary overcirculation. The right ventricular end diastolic volume and the end diastolic pressure will be high, and therefore the coronary perfusion will decrease, and the RV systolic function will be impacted in a higher level than the rest of the surgeries. To the contrary, when we do an RV to PA conduit, even though we are still in a pulmonary overcirculation stage, the the right ventricular end diastolic volume and then diastolic pressure are not probably as high as on the BT Shan, and therefore the coronary perfusion will stay more stable through the course, and the RV systolic function might be a little bit better than the other cases. And if we take the example of the hybrid, just having two restrictors of flow, both in the PAs and also in the PDA, might have an impact on the afterload and might have a significant decrease of the RV systolic function of those patients. So all those things need to be into account when we receive a patient, and then we need to anticipate what is coming. And we need to anticipate bleeding, the low cardiac output effects, the high likelihood of arrhythmias, the presence of acute kidney injury, the importance of neuromonitoring those patients to prevent CNS dysfunction and other comorbidities that might appear during the postoperative period. I just want to highlight a couple of things that are important in the postoperative management. One is the meticulously assessment of fluid status, and to make sure that the fluid that the patient receives has an osmotic power that doesn't worsen the overall hypervolemic status of these patients. So it's always better to give albumin, to give FFP, or to give colloids to these patients in the immediate postoperative period, that giving crystalloids and putting free water into the intravascular vessels. One of the things that we have learned over time is that we should not give volume trying to chase numbers. Too much volume is associated with morbidity. We have learned that from the sepsis literature, and we know now that after years of giving too much volume, we have been negatively impacting the course of our patients. And this is particularly important in the ICU. In a patient that has a decreased ventricular performance with an increase in diastolic volume and an increase in diastolic pressure, giving volume if he doesn't need it will negatively impact the coronary perfusion and might trigger an arrest. So yeah, just give volume, but just the right amount to our patients. And then we have to support cardiac output. We have to use drugs, but the less the better, and just try to stay away from dogmas that might not apply to our patient population. So if you see this slide, you don't see milrinone. So sometimes we just take things for granted. And those patients that do not need milrinone, they should not receive milrinone. We know that there's studies that have changed the course of cardiac ICU, and I'm relating to the PrimaCore study that extended the use of milrinone, but sometimes just treating patients because studies that do not apply to that particular anatomy say so might be detrimental for our patients. Another important thing is understand arrhythmia, how to treat arrhythmia. Try to easily identify the mechanisms that translate to treatment. It's easy to treat a re-entry tachycardia in the postoperative period. It's more difficult to treat an automatic tachycardia. If we have an automatic tachyarrhythmia in the postoperative period, we are probably talking about junctional ectopic tachycardia. And if we are talking about re-entry tachycardia, what we have to do is to diagnose it and treat it appropriately. Our patients are always brought back to the CICU with atrial wires, which give us the opportunity not just to diagnose, but also to treat in the event of a re-entry tachycardia, or to pace them in the event of a bradycardia, pharmacologically induced or surgically induced. At the end, I think that there is important concepts that we have learned over the years about how to best manage those patients. And I try to highlight those ones here in this slide. I think that those are probably the most important things that I have learned from managing these patients over years. I now understand the importance of the delayed sternal closure, trying to not just to minimize the amount of a transmural pressure that affects to this ventricle, but also impacting on the interpersonal variability in the immediate postoperative period. Having a patient with open chest ensures that the patient will be with sedation and paralysis and will avoid swings in opioids or other medications. A peritoneal drain that just passively drains the belly content will help achieve a negative fluid balance necessary to recover the myocardium, and also will help to restore the diaphragmatic organ perfusion. I said that the importance of the neuromuscular blockade in patients with delayed sterile closure, but also the decrease on the inputs that those patients have will also help to decrease the amount of sedatives that we will need to deploy to achieve a good comfort control of these patients. So that is, try to minimize the amount of sedative in order not to impact negatively to the hemodynamics of these patients. Try to provide a rational approach on our inotropic support, try to do less, and try to minimize the amount of drugs. It's easy for us to put a lot of things, but the really difficult thing to do for an intensivist is to know how to decrease, when to remove things, achieve a good temperature control, and obviously continuous neuromonitoring throughout the case to avoid and to anticipate neurological complications. It's important to have a start as a surgeon. We need a good team, but we need to work as a team. And we know that from years and years of working in ICU. It's not about one person, it's about a team that works together. So we need to be prepared, we need to anticipate, we need to monitor our patients, we need to diligently follow the trends. And something that is very, very, very important, you have to be quick, but do not overreact. Just bring the team to the bedside, work together, and try to keep things as simple as possible. In an ICU, it is easy to make something very complicated and keep adding things, but the really hard thing to do is to keep things simple. Thank you very much.
Great, John. Thank you, Joanne. Next speaker is me. I'm going to be talking about the role of interventional cardiology and pre and post-stage palliation. I have to say I'm going to focus a little bit on hypoplastic left heart syndrome in this talk. Just the role of cath at the different timings, starting from prenatal on. These disclosures are not particularly relevant to this presentation. So I'm going to cover the different stages before surgical palliation, postoperative, and interstage, the beginning, and some recent innovations and some case examples and conclusions. Starting with very early, we have to cover a little bit of the role of interventional cardiology in prenatal univentricular heart, especially interventions which are rarely performed in some centers and more in others, such as creation and dilation or stenting the atrial septum in hypoplastic left heart syndrome with intact atrial septum and aortic valve balloon valvotomy. Focusing first on the intact atrial septum in hypoplastic left heart and fetal diagnosis, the group in Boston in 2004 demonstrated the initial experience with that in a few patients in whom through a needle where we're able to transverse the atrial septum, and then you can deliver put a coronary balloon through that 19-gauge needle and then open the atrial septum as being successful. Still, however, of those 7 patients, 4 of them ended up dying. So, obviously this is a really bad condition with very poor prognosis. So these interventions may or not really change the outcome of these patients. In this other publication, you have a very beautiful illustration of the impact of that high left atrial pressure in fetal life. We know there's many contributions by others that also show how those high pressures in the pulmonary veins can have significant impact on the development of the lungs and the pulmonary veins in these patients. And in this group, you can see the delivery of a stent, and that can be delivered through an 18-gauge needle directly in the atrial septum, and then lower the pressure in the left atrium. So it's clearly feasible, but these patients are clearly have very poor prognosis. Fetal aortic valvuloplasty, that's a procedure that particularly pioneered by several, but especially the technique has been perfected by the group in Boston. We know that some fetuses with aortic valve stenosis present at mid-gestation with a dilated left ventricle and arrest growth, and that, the idea of fetal intervention is to prevent the development of hypoplastic left heart syndrome. And there have been specific parameters that help you identify who these patients, these fetuses are. The technique includes it ultrasound guided, can be done percutaneous or laparoscopic, although most of the time is percutaneous. The fetal position is key. And then through that 19-gauge needle, you can deliver a coronary balloon across the aortic valve, like is illustrated here, and open the valve that way. What are some of the data, what are the results of this fetal intervention that we know? This is actually a meta-analysis of a large number of studies that had at least a significant number of fetal valvuloplasties performed, and the total was 389. This is published recently. There was really high rates of technical success that you can see over here at 84%. However, a fetal mortality of 20% and a successful biventricular circulation achieved give you an idea of about a third of the patients, ranging, you can see in some up to close to 40% on some centers. I think that's Boston. And then potentially postnatal univentricular circulation, another third. So it gives you an idea of this intervention can possibly lead to a biventricular circulation in a third of those fetuses. Now, I think we have to recognize that when you look at the data from the Boston group, that these biventricular outcome patients are not really perfect biventricular patients, okay? So the insult to that left ventricle, that's not going to be a normal left ventricle in most of those patients. You can see here the significant number of interventions that these babies may have had. So these are the biventricular babies from birth. And you can see, especially when you look at 39% of neonatal Ross procedures. Okay, well, that's a significant surgery. Mitral valve replacement, 16% aortic valve replacement. And in the ones that were converted to a biventricular, so they did not start, but they were rehabilitated over time, there's a significant number of babies that end up having procedures such as 86% EFE resection, mitral valve repair, mitral valve replacement, 43%. We all know that toddlers with mitral valve replacement are really extremely difficult to manage. So I think it's so important. This is not just a matter of ballooning an aortic valve, it's a complete program to rehabilitate the left ventricle. And for that 1/3 of patients that may actually achieve biventricular repair, you have to understand that the commitment for ongoing rehabilitation has to be there. And it would be wonderful if we could identify what are the predictors for a successful biventricular repair that does not require mitral valve replacement and that ends up with a healthy left ventricle. Because the issue is that there's a big price that all those other babies are paying because they end up in a situation where it's pretty suboptimal in terms of their physiology, and sometimes not even being able to be candidates for transplantation because of the chronic left atrial hypertension and pulmonary hypertension secondary to that. So the story still needs to be told, I think, about should we all be doing this or not. Now, after birth, what do we do after birth? Well, prior to stage 1, clearly one of the interventions that we perform in these patients that sometimes can be emergent is the left atrial decompression in babies that have restrictive atrial communication. So especially in the hypoplastic left heart syndrome with complex with mitral atresia or mitral stenosis and restrictive atrial communication, it's rare to have to do emergent atrial septostomies in patients that have right heart obstructive lesions. Obviously, because of the PFO anatomy, the higher right atrial pressure tends to keep it open, so it's rare. But sometimes we do have to do a septostomy in a pulmonary atresia, intact septum, or a tricuspid atresia, but they tend to be rare. And all of these techniques include the traditional septostomy, static balloon dilation. Sometimes with this intact septum, we have to create a transseptal puncture, sometimes in collaboration with the CTO wire or placing a stent or radiofrequency assisted perforation. So, it always comes the issue when you have to do a septostomy in these babies, can you do it at bedside in the ICU? Clearly, if you have a thin atrial septum with a PFO and you have an umbilical line that enters the heart, it should be preferred to do in a cardiac ICU on the bedside. Now, for these babies with hypoplastic left heart structures, that is typically not the case. So no, this should be done in the cath lab. You need all the help possible. Sometimes you may even need TE guidance. And so it's very, very important to have all the views and all the tools you may need and to be in the cath lab for that. Sometimes this is done emergently as the baby is born, gets immediately transported to the cath lab. Sometimes they're semi-emergent, there's some restriction and it tends to progress over time, and then we decide to go to the cath lab because of progressive pulmonary edema and a higher gradient that's documented on the echo. This actually is one of Diane Spicer's heart specimens, but you can see that the anatomy of the left atrial septum in these babies, and this is in this echocardiogram, can be pretty tricky. In this case, it's intact, but in here, you can see that there is an opening, and it's not uncommon that you have a posterior deviation of septum secundum here, and so it's like a tunnel. So the tricky thing is to get the septostomy balloon on the other side of this tunnel, and that can be sometimes extremely difficult. This is the baby we had this week, emergency transferred to the cath lab after birth, and had a gradient of over 20 across the PFO, and had this tunnel, this double, so septum primum here, septum secundum here, and you can see that here we were in the middle of the tunnel. This is a lateral projection, a wire was across, did balloon dilation and didn't do anything because the flap was still occluding. You can see a left atrial injection here with a pulmonary vein filling. Finally, we were able to get the septostomy balloon to the other side of this membrane, and we were able to do the septostomy, which really succeeded in tearing that thin second membrane that there was in the atrial septum. You can see when the left atrial pressure went from 20 to 7, how much smaller that left atrium became. So this left atrium appears good size, but it is because it's distended and hypertensive at high pressure. So sometimes we have to do a transseptal puncture in an intact atrial septum, and those are really tricky, especially if the left atrium is really small, as some of these babies may have. And there are occasions when you just have, if it's very thick, the best option maybe just go directly and do a surgical septectomy because of the difficulties that we may have in the cath lab, open an intact septum with a tiny little left atrium on the other side. So then, as a cath doc, we have to talk about the hybrid procedure because obviously that typically involves stenting of the PDA. So this is really a combination of the CT surgery and interventional cardiology working together. The key things for a hybrid procedure is providing an unobstructed systemic output through a PDA ductal stent, and restrictive atrial communication, which is often done with either septostomy balloon or atrial septal stent, and then protecting the pulmonary bed with typically bilateral pulmonary artery bands. As these ducts are large, the stents that are used are self-expanding stents, as opposed to balloon expandable stents that we reserve those for the very much smaller. If you have a preemie, you may be able to use those. The ductal stent is implanted directly through the main pulmonary artery, as introduced by the group in Nationwide. And most patients are candidate for a hybrid procedure, but there are some anatomies of PDAs. And when you have this retrograde obstruction with the 3 sign that Mark Busek many years ago described, in Colorado, these patients are not good candidates because you stent the duct, you occlude you can cause retrograde aortic coronary stenosis, aortic obstruction. So those patients may not be candidates. So that's important to look at the PA anatomy. Now, most recently, we have been able to avoid the use of pulmonary artery banding, and some of these babies can have a complete percutaneous procedure where flow restrictors, this is the modified Medtronic microvascular plug. This was introduced published in 2021 by Shan Sathanandam and Not Craig in the group in Le Bonheur. You can cut little holes in the microvascular plug and then deliver those at the branch PAs, and that restricts the flow. One of the problems with these is that they can move forward, move distally, and sometimes they're tricky to retrieve. This is another publication showing how in Europe they're retrieved using a snare intraoperatively to try to get them out because they go distally, and so the surgeon doesn't have to dissect the pulmonary artery to get them out. But so they're a little tricky, but that offers a new option for some of these babies that we do not want to necessarily open the chest and deliver these in the cath lab. They can be done through a 4 French catheter. In our experience, we started doing hybrid procedures in 2009. John mentioned a little bit of that. We had looked back at our data, and the low-risk Norwood babies had a mortality of about 80%, while the high risk had 25%. And the risks of these patients, this is before 2009, these were the risk factors that really, those babies had a worse outcome. So from then on, we started doing hybrids on all these high-risk babies, and then compare the results of hybrids to high-risk Norwoods. And in this initial study that we published in 2018, there was not a real survival benefit of a hybrid procedure for all these patients at 1 and 5 years. However, for some risk factor, this was. So if you had a premature infant, that was a significant survival benefit of using the hybrid procedure in our experience. And of course, hybrid procedures have been used throughout the world. In this analysis from the Congenital Heart Surgeon Society on the critical left heart obstructive lesions, this is published quite recently. There were 214 hybrids and 831 non-hybrids, and they were compared. And in this series, there was no significant survival benefit, even when they were looking at weight. I have to say, though, that, well, you know, whether you have a hybrid or you have, you know, a Norwood, if you have a high-risk driver, the outcome may not be very good, okay? So the issue is that you have to realize that there's a few things in these studies or results of the hybrids. First, there were patients that didn't make it to any surgical series that were not offered anything because they were not candidates for a Norwood, and now we're offered a hybrid. So it's when you're comparing the two, you're not being very fair because those patients would not have been offered anything. And there are some some patients that are not even candidates for a hybrid. I mean, they would be death versus hybrid. So those are the options, right? Because maybe they have a brain bleed or some issues that can't really go for a Norwood. And the other thing is that not all risk factors are the same. And so there are some risk factors, such as if you have multiple congenital anomalies, that's not going to go away when you come back for a Norwood 2 months later, okay? You're still going to be high risk. So, and there are some risk factors that are transient. If you have, it could be that you have decreased ventricular function because of a traumatic delivery or something like that, that gets better. You can get them through a hybrid and maybe they recover and they'll be a relatively good risk Norwood if they recover. So there are risk factors that can change and others that persist. So I think that that's the truth. And the other thing is a lot of the use of the hybrid, there's a very significant patient heterogeneity. So hybrids is also used for staging biventricular circulation. or in borderline left hearts. And those patients don't end up going for Norwood, end up going for biventricular repair. So we have to recognize that that makes the data pretty dirty when you're looking at some of these publications, is because patients are not all the same. What do we do in this interstage monitoring after a hybrid? It's similar that we do after Norwood. Cardiology assessments every 1 to 2 weeks. We check for PDA restrictions, retrograde aortic flow. We check for the atrial septum. It can develop restriction. Any signs of decreasing function, of increasing tricuspid regurgitation can be a sign that you need to come to the cath lab, especially if they're not doing well clinically, and they routinely would get cathed in preparation for the next step. Unfortunately, bilateral PN bands sometimes causes trouble, and we see patients with pulmonary hypoplasia or pulmonary artery stenosis that can be difficult to treat. Sometimes we balloon those patients. Restriction, we obviously can do a septostomy. The other thing, PDAs, the PDA, the stent sometimes moves a little distally and you can develop obstruction proximally. This happened to be a patient who was never a candidate for Norwood and lived with a hybrid for 6 years. And then you can see the develops restriction and we had to restent. There's also retrograde obstruction here that can be ballooned and sometimes can be stented. So these can be managed in the cath lab, but sometimes when you see this is the timing to go ahead and do an Norwood. So you don't have to do anything because they are going to go for surgery. The group in Toronto, they reported years ago that if you had retrograde aortic obstruction, you can treat this with a reverse Blalock toxictoma shunt. So this is a shunt from the main pulmonary artery that will go into the innominate artery and will flow the opposite way and feed the coronaries. So that's a potential surgical solution to that. So before the Glenn, interventions that we get to do include interventions on the shunt, whether it's a Sanos or Blalock toxictoma shunt, coarctation dilation, embolization of collaterals, pulmonary artery interventions, atrial septoplasty, and of course, these babies are sick and are having lines and can develop obstruction in the systemic venous pathways, and we often have to intervene in the cath lab and open them up. For interventions in the BTT shunt, sometimes you have to go through the neck, depending on the angle that we have, and we can flip the baby, and we do that also for the ductal stents when the access has to be carotid or axillary. To make it just easier for the operator. Sometimes you need to make it a little easier enough. And Sanos also can become obstructed, and these can be stented and treated in the cath lab when you have Sanos obstruction. We know very well results are very good for coarctation intervention, and collaterals, a mesh of collateral vessels are not rare in patients with single ventricle in the early stages, and we use a combination of particles and coils, mostly particles, to lower the collateral burden. We always look for potential decompressing collaterals in the pre-ligand cath. It is very important if you have a left SVC to a coronary sinus that you do document that the coronary sinus is not atretic, because that's a contraindication to doing any closure, of course, of that left SVC. Obviously that can be closed in the cath lab before or after the Glenn. We also, after the Glenn, would obviously be treating potential obstruction. It can happen with clot formation. There's different systems that we use in the cath lab to open up obstructed vessels by clot, including angiojet and the penumbra system, which is the one that we're using mostly lately. And this is an example of bilateral bidirectional Glenn with complete occlusion and how it is opened up. And we all know very well that a large knee aorta after Norwood reconstruction can end up obstructing the left pulmonary artery, and stent implantation is the procedure of choice for that, since a balloon alone would not do anything, since there is external compression. So in conclusion, we can say that cardiac catheterization plays a major role in the management of patients with univentricular heart in the early stages, and this role continues to evolve, as we've seen with some of the novel incorporation of new technologies, such as the flow restrictors, as well as the incorporation of the hybrid technologies. Thank you very much. So advancing a little bit more with invasiveness, we're going to talk about the role of surgery, surgical management in the early stages. And this will be presented by Dr. Mario Castro Medina. Mario is Assistant Professor in Cardiothoracic Surgery here at Children's Hospital of Pittsburgh. Mario.
Thank you. Well, I would like to say thank you for the committee for the invitation for this presentation. I don't have I don't have any conflict of interest. I just want to tell you guys that I was born raised in Chihuahua, for those you guys don't know. So the objectives of my talk is present the Children's Hospital of Pittsburgh experience and the different strategies for the Norwood procedure. The reality is that the Norwood procedure is basically a few parts of the surgery is create a good flow to the pulmonary arteries, that is the BT shunt or the Sano shunt, is the aortic arch reconstruction, and basically do the DKS. So reality is not that difficult to do a Norwood procedure if you divide in your mind in basically these 3 steps. So first we need to create a good BT shunt, make sure we create a good aortic arch, and the creation of the flow to the pulmonary arteries. So on the DKS, it's very important to have in mind that we don't have any torsion of the coronary arteries. And the 3 different approach that we can do is the standard Norwood, that is with the BT shunt, and the Sano, with the other one is with the Sano, and the third one is the hybrid procedure that in our institution is basically for the high-risk population, as Dr. Kreitzer already mentioned. When you have a Norwood procedure, in your mind always needs to be that if you're gonna cannulate the PDA, if you're gonna do selective cerebral perfusion, that in the last probably 5 years or 7 years in our program, we're doing the selective cerebral perfusion. It's still using hypothermia. We're still using the homograft and the BT shunt between 3.5 millimeters, 4 millimeters. And the Sano, usually we do the dunk technique. In our program, the Sano technique is basically for the patients who have any aortic abnormalities of the aortic arch that they're not a good candidates for the Norwood procedure, or if we're thinking that it's a high-risk patient in the unit, like a low birth weight, that it's between the 2.5 to 3 kilos, not less than 2.5 kilos, that we might consider use a BT shunt. Also, maybe like Dr. Sanchez de Toledo say, who's in the ICU. So in the consideration on the Norwood procedure, always have in mind that I think that game changer for all the new surgeons is using the selective cerebral perfusion, because that gives you time and you don't need to run for the circulatory arrest. So that gives us an advantage at the time to planning the procedure. The DKS is the most important part, so that at that moment we don't twist the coronaries, because if we have any coronary problem, at this point there's no turning back point on this patient. So that needs to be very important in the surgeon's mind at the time doing the DKS. Also, all the time during the bypass, you need to keep an eye on the heart, make sure there's any electrocardiogram change, so that we don't have any ischemia. And for the reconstruction of the aortic arch, we usually use the D-cell homograph. We used to use sometimes bovine pericardium, and basically is to enlarge all the way to the descending aorta to create a new aorta all the way down. So those are the main steps for doing a Norwood procedure. Now on the dunking technique, this is usually a Gore-Tex ring that usually, as the technique say, we dunking in the right ventricle. So the rings are protecting the graft to be stenotic at the time of the contraction of the ventricle. So those are the different techniques. So in our experience, so I'm gonna show basically from 2004 to 2020, I reviewed this data for our experience as a Children's Hospital of Pittsburgh, and basically to see what is the transplant-free survival at 1 year, the 30-day mortality, the discharge survival, the interstage mortality, and the completion of the palliation and the long-term survival among these survivors. And you will see that this is the characteristics of the patients. We divide between 2004 to 2009, 2010 to 2014, and 2015 to 2020. And then you can see the difference between these patients. You can see that in the late years, we were taking care more of the patients who has any syndromic disorders or they have any chromosomal abnormalities. Also, you can see here the weight of the patients in some of these variables. And these are the other characteristics about the patients. What is the diameter of the ascending aorta? What are the C-scores on the pulmonary arteries? That basically in our program, there's no, any size of the aorta, there's not a contraindication for doing Norwood, but we look this data to present. Also, you can notice that it changed, that these high-risk Norwoods, that they have ventricular dysfunction or valve insufficiency in the late years. Basically, we did not do all those Norwoods because probably we did for the hybrid procedures. This is where the anatomic characteristics of these patients is a total of 140 patients, and you can see that the most common were aortic atresia and mitral atresia. You can see on 29%, Chon complex was 13%, and the other variants were very, you can see here in these slides, like that one in the left ventricle is only 4.3%, and this is based on the different years that we divide these patients. You can argue that the hybrid, in the last years we did more hybrids, and you can see that these hybrids after that paper that Dr. Kreitzer and Dr. Morel write it, that's when they describe the high-risk patients for our Norwoods, and basically we're the ones who have dysfunction, we're the low birth weight, and those were the ones who consider to do for a hybrid procedure. You can see in this data that basically we're not a very strong program using the Sano shunt, and I know that everybody will argue that the single ventricle trial will do a lot of Sanos because they show better survival, but in our data, in our hands, we were better with the BT shunt. And you can see that in the last years, from 2015 to 2020, our times of bypass time are longer. And what that means is because we have a group of young surgeons that are performing the operation. And in the last 5 years, we're changing from using selective cerebral perfusion. So you can also see it on this in the cross-clamp time and the cardiopulmonary bypass time in this data. Now, the outcomes of after the Norwood, you can see it how they changed through the years. And the ECMO on Norwood, we probably in the last 10 years, we're more aggressive using ECMO in this to rescue these patients. It's a decision that we don't delay. And if there's any doubt or there's any consideration for any residual lesion, we just go on ECMO, and we're not afraid to cut these patients or looking for any residual complications. Now you can see that interstage mortalities, these are our numbers, 4.9%, and our they went to a Glenn procedure, 92%. So those are basically our numbers. Interstage mortality, 4.9%. So those are in this different era. Now you can argue that from 2004 to 2009, the interstage mortality was 2%, but to 2015 to 2020, we have more kids with some genetic disorders. The other thing we can argue that in the last years, so we start doing some of these patients with the intact atrial septum. And from shunt revision, this is we did a chart on these. The patients that need any shunt reintervention can be catheter-based procedure or surgical procedure. This is where our numbers. I'm not gonna go into in the different situations, but I just wanna show that we're not afraid in our program to cut the patients and solve the problem. because in our mind is move the patient forward so we can rescue this patient and send them home. Now, the overall long-term survival, you can see at 10 years, we have 70% of survival in our group of patients that had a Norwood. You can see it as at 10 years. Now, the transplant-free survival at 1 year after the Norwood, you can see that in the last, from 2015 to 2020, we have a survival of 90, free of survival at 1 year, 92%. So this is our numbers that we look at in this cohort of the study. Again, in the 1 year transplant-free survival among the discharge survivors, you can see 94%, and it's higher at the 2015 to 2020. So our conclusions is basically, as Dr. Sanchez mentioned, and Dr. Kreutzer, you need to establish your team approach. For my always remind to use selective cerebral perfusion. Don't be afraid to reintervene or cut this patient to find some problems. And one of my recommendations will always learn how to manage ECMO in the first stage. And that will be my talk. And thank you so much.
Thank you, Mario. I think I didn't see there were a lot of questions coming in the audience, and we're running a little over time. So maybe we'll do the panel discussion at the end with everyone. And we'll proceed with our next speaker, and that's Dr. Melita Viegas. She's assistant professor in cardiothoracic surgery here at Children's Hospital Pittsburgh, and she's going to be talking about mechanical support in the early stages of univentricular heart palliation. This talk is recorded as Melita is unable to be here today. All right, well, we're having a little bit of trouble with the sound for that presentation, so we will proceed with our next speaker and then move to that one later. And Dr. Jake Bray is here with us. He is a pediatric cardiac anesthesiology at Altner Hospital in New York Medical Center in New Orleans. And so he'll be talking to us about anesthesia consideration in this patient population.
Just click through with the mouse, I'm assuming. I'm sorry? Okay. All right, I want to say thank you for you guys inviting me up here. I did all my pediatric and congenital heart training here, and so it's a pleasure being back. So like Dr. Kreutzer said, I'm going to talk to you about some of the anesthesia considerations in the univentricular heart. And really, when we talk about anesthesia and the consequences of anesthesia, it sort of primarily revolves around the pathology, first off, that the kid has. And that really sort of dictates the physiologic consequences that we're sort of going to be trying to manage. And whether that's sort of how we affect that physiology from the drugs we give, or a variety of other things like the way we ventilate the kid, which we'll get into here in a little while. And that's sort of true whether or not we're at the sort of pre-surgical repair stage or the first stage, second stage, or all the way over to Fontan completion, which we'll talk a lot about here in a little while. And so when we're sort of talking about Fontans and how they compare to biventricular hearts, it's really important to sort of note that in a univentricular system, there's really only obviously one pumping chamber that inputs sort of kinetic energy into the system. And that's at a time when those sort of univentricular hearts are at an increased workload for those systems as compared to a biventricular system. And so when you look at the hydraulic work that these hearts actually have to do, it's significantly more than a biventricular system at a time whenever they're only able to sort of generate a lower cardiac index as compared to a biventricular system. And so when they sort of pump blood through the circulation, they not only have to overcome the resistance that we normally think of as a sort of typical systemic vascular resistance, but also the resistance of the sort of entire cardiovascular system. And when we think about this from a pressure standpoint, blood comes into the single, or the univentricular heart, I should say, is pressurized into the aorta, and then that blood has to flow down a pressure gradient all the way down back to the LA and the univentricle. Or single ventricle. And when we talk about ventilating these patients, it's really at this sort of cavo-pulmonary junction that we really start to affect these things. And so as sort of Jawan was mentioning earlier, during normal ventilation, we create a negative intraalveolar pressure, and which corresponds to a negative pleural pressure, which allows us to both pull air in during normal inspiration, but it also sort of augments the pressure gradient that's generated from the abdominal IVC all the way up into the thoracic cavity, sort of augmenting these patients' pulmonary blood flow. And we change that a lot whenever we start talking about putting these kids on positive pressure, where you create a positive alveolar pressure now, which is corresponding to a positive pleural pressure, and sort of decreasing that gradient that exists during normal spontaneous respirations. And this was looked at recently when comparing normal biventricular hearts to 6 Fontan individuals. They looked at this under MRI while these patients were sort of spontaneously ventilating, and sort of measured the flow through their IVC, SVC, the main PA, and then their corresponding bilateral PAs, and analyzed that throughout the respiratory cycle. And what they saw is that in normal biventricular volunteers, you did see an augmentation of preload, or an augmentation of flow through those structures, but it was greatly exaggerated whenever we look at the Fontan circulation. So in the IVC, they saw an increase of roughly 60%, in the SVC, roughly 25%, and then in the branch PAs, on average, roughly 45%. And not only did they get an increase in flow during the normal inspiratory cycle, but the decrease in flow through the expiratory phase was also exaggerated when compared to normal biventricular individuals. And now from a medical standpoint, we can actually augment this non-invasively through what's called non-invasive negative pressure ventilation through these Caras ventilators, which is essentially, you can almost think of them as somewhat of like a portable iron lung in a way. And so when you take Fontan patients and hook them up to this device here, it creates a negative sort of vacuum within, or negative pressure within this chamber, and allow them to sort of spontaneously ventilate with this. you can actually augment their hemodynamic variables and stuff. And so that's what this group sort of assessed. So they took 18 patients. Some of them were placed on invasive positive pressure ventilation via ET tube, and then other ones were placed on this sort of non-invasive negative pressure device. And then they evaluated the hemodynamic variables through thermodynamics. And so what they saw was basically that the patients who underwent negative pressure ventilation, they had increased pulmonary blood flow, increased stroke volumes. Their mean PA pressures were lower, their pulmonary vascular resistance was lower, their SVO2 was higher, and then their VO2s were higher as well. And this held true for what they described as their acute patients, which were within a few weeks after surgery, and also for what they described as their convalescent patients, which were a few years after surgery as well. And a subset of patients, they also took a group and had them intubated and on positive pressure. They obtained baseline measurements and then switched them to non-invasive positive pressure, or negative pressure, I'm sorry, and then switched them back to a positive pressure mode, and their results still held true. But what about the older sort of Fontan patients? This study is on a group of individuals roughly 24, 25 years of age. And then the interesting thing that this group did was they took the negative pressure device that we looked at earlier, and instead of having a set negative pressure of negative 20 or negative 30, what they did was create a sort of bi-level pressure mode, which would correspond to an inspiratory pressure. So the device would generate a negative pressure of negative 27, and during the expiratory phase, it would generate a positive pressure of 7 to somewhat simulate the mild positive pressure that you would see during negative expiration in the intra-abdominal cavity, with the idea of sort of hoping that you would see a improvement in the cavopulmonary gradient. And so they looked at all these cardiovascular variables via MRI. They obtained the baseline measurements with these patients, non-sedated, undergoing MRI, and then connected them to negative pressure, their sort of static negative pressure at 30, took another measurement, had a washout period, and then instituted the bi-level ventilation strategy that I mentioned earlier, and went ahead and took another set of measurements. And what they saw, particularly in the bi-level setting, is that within the Fontan circuit, they saw significantly increased flows. Again, in the subhepatic IVC, they saw increased flows as well within the hepatic veins. And the pulmonary blood flow was increased, as well as the cardiac output, particularly so in the bi-level setting group. And interestingly enough, when you ask these patients, how did this make you feel, and would you want to do this again? Subjectively, the patients who experienced the highest increase in pulmonary blood flow and highest increase in cardiac output sort of mentioned that, it felt pretty good. I would like to do that again, which subjectively, it also made these patients feel better as well. And so what about positive pressure, and how do we influence these circuits whenever they come to us in the OR or cath lab or wherever else? And so from our earlier studies in sort of the mid-80s, we know that adding PEEP to these circuits was shown to significantly decrease their cardiac index, and particularly with PEEPs over 6, although there was still a trend to sort of a lower cardiac index as PEEP goes up, but it proved to only be significant when they were, in this study anyways, for PEEPs greater than 6. It was shown to increase their PVR during this period of time and also increase oxygenation. So again, increased oxygenation for these patients while adding PEEP comes at a cost of reducing their cardiac index. And so this sort of brings us to the UPMC group here, which wanted to assess the effect of tidal volumes on these circuits. And in particular, the strategy of higher tidal volumes versus lower tidal volumes. And historically at this institution, we would ventilate these children on a higher tidal volume setting with longer expiratory times and shorter respiratory rates, with the sort of thought that you are limiting your time at higher peak pressures and allowing for more passive flow through your Fontaine circuit. And so to assess that versus a lower tidal volume strategy, they took 30 patients over a period of time that were going to the cath lab. They randomized them into a high tidal volume group and a low tidal volume group, allowed them to equilibrate on that those strategies for a period of time, took hemodynamic measurements, and then transitioned to the other group, and then took measurements again. This is the sort of characteristics of those patients. Most patients were around the age of 10. They all primarily had systemic right ventricles, roughly 70% or so, and 70% as well had normal biventricular function, and the majority of them, 60%, had fenestrations present at the time of catheterization. So when comparing the low tidal volume group to the high tidal volume group, when looking at variables attained on their ABG, basically their pH, PaCO2, PO2 was not statistically significant. There was no difference in those variables, as well as their hemodynamic variables as well, their MAPs and PA pressures. The only statistically significant variables were the ones that we were manipulating, mainly the tidal volume, manipulating their respiratory rate depending on their what group they were in, and as expected, the peak pressures were higher in the higher tidal volume group. And then when looking at other hemodynamic variables, so QS was not statistically significantly higher in the low tidal volume group, although it did trend to for that to be true. The pulmonary blood flow was the same in both group, as well as QPQS, the resistance at the pulmonary vascular level and systemic level as well. And so what should we really do, and how should we think about these patients whenever they present to either the OR or cath lab, or for any sort of outside area procedure? I think it's sort of appropriate to assess these patients for the need of either mild to moderate sedation while maintaining spontaneous ventilation. Although I don't think that should come at a cost of potentially either risking an airway complication or risking sort of having to instrument the airway emergently. And so I think if you need to intubate these kids, I think that's fine, and more appropriate a lot of times than not. But having in the back of your mind what the cost of intubating those kids are, and having a strategy to deal with your method of ventilating them. So I would suggest moderate tidal volumes with avoidance of larger tidal volumes. Limit PEEP as much as possible. Adjust your respiratory rate to maintain physiologic parameters. And consider lengthening your E times as well, your expiratory times, and sort of adjusting your FiO2 as needed, with the goal of getting these kids extubated in the OR, if at all possible, or setting them up to extubate as soon as you get to the ICU if you're concerned that they need more invasive respiratory support that you couldn't provide in the OR. So thank you.
That was superb. Thank you so much. The next speaker will be Dr. Yvonne Morel. Yvonne is Associate Professor of Pediatrics here at University of Pittsburgh, Department of Pediatrics, and she's also Director of the Inpatient Services in Cardiology. And she will be talking about interstage care and pre-glen management.
Thanks for the introduction. So I'm going to speak today on interstage care and pregland management. So the single ventricle interstage period has been historically defined by the American Heart Association as the time between discharge from the initial palliative procedure to the time of the second stage palliation for the infants who are shunt dependent with single ventricle heart disease. Historically, this is associated with high mortality rates. This is because there's parallel circulation, which creates a dependent relationship between pulmonary and systemic blood flow. The arterial blood oxygenation depends on the balance between these two systems, the pulmonary vein saturation and the systemic venous saturation. Anything that affects the balance of these things can critically affect the oxygen delivery to tissue and lead to major adverse events. Interstage death can be due to multiple reasons, recurrent or residual lesions resulting in the change in oxygen saturation, typical childhood diseases like viruses and URIs, or even arrhythmias. Study demonstrated breaking down to BT shunts and RV to PA conduits. In both groups, there was at least around 50% reintervention during this interstage period. So it's common and happens frequently and have to be monitored closely in order to prevent a major adverse event. So within the acute care unit, our interstage management focuses on maintaining hemodynamic stability with acceptable oxygen saturations. We do this with titration of oral medications in the hope that we can transition them to home. We focus on using ACE inhibitors, digoxin, diuretics, and antiarrhythmics if needed. We also, one of our hardest objectives is to achieve a stable feeding regimen that provides adequate growth. We aim for 20 to 30 grams per day. We typically always have to use fortified formula up to about 24 kcal per ounce. And it's often a combination of NG or ND feeds with our oral feeds. Looking back over the last 10, 15 years, about 90% of our patients do need a combination of an NG tube with their oral feeds. As neck is a particular concern during this high-risk interstage period, we implemented a high-risk feeding protocol to standardize the feeding approach to our patients. Typically, just after surgery, they're not deemed appropriate for PO feeding for many reasons, and so a PE tube should be placed, and we can initiate feeds either by bolus or continuous. Either way, they're started very slowly. If you're using intermittent feeds, it's 2 mLs per kilo every 3 hours. And if continuous, it's somewhere between 10 to 20 mLs per kilo per day. In order to advance this, we do that also very slowly and watch for signs of intestinal compromise. If they're on bolus feeds, we'll increase 2 mLs per kilo every 12 hours, and continuous is 2 mLs every 12 hours. With a goal of 100 mLs per kilos per day. And so it takes us a long time to get there, and we use TPN and lipids to meet our caloric goals during that period of time and titrate that down as we titrate up feeds. So another very important aspect of acute care management is caregiver education. This starts immediately upon arrival to our acute care unit. It covers quite a bit. Caregivers are expected to understand what equipment they're going to have to use, how to administer the medications, how to make daily measurements of their baby in weight, pulse ox, and among other things, how to use, if going home, potentially a home monitoring device, like a pulse ox, and then how to use the telemedicine programs. So as you can imagine, this is a significant amount of demand on the family and can create significant family stressors. There's a study that was published that looked at families with hypoplastic left heart syndrome, and they did surveys at 3 different time periods and compared them to adult norms. And it was found that the quality of life and well-being of these families is significantly lower than when compared to adult norms. And then they, drilling down a little further, looking at moms versus dads, mom's quality of life and well-being was significantly lower than the father's. So a meta-analysis was done of the literature looking at complex congenital heart disease and parental mental health. And it was found that parents of complex congenital heart disease patients are at significantly elevated risk of psychological problems. Almost 30% of the people that were surveyed have PTSD. More than 80% presented with clinically significant symptoms of trauma, and 20 to 50% report symptoms of anxiety and/or depression, and 30 to 80% reported experiencing severe psychological distress. So knowing that and understanding that, over the last few years, it's become a focus for the cardiac unit at Children's Hospital. And several programs have been implemented, both looking and focusing on making the hospitalization experience for the families better, understanding and screening for maternal depression, and most recently, formation of a family advisory board in the hopes that we can understand where the stressors are and how to improve those during the hospitalization. Some centers have even hired a dedicated psychologist because of the importance of maintaining our parental mental health, as they will be the sole providers when they go home. So our patients who we feel would be ready for discharge need to have demonstrated long-term hemodynamic and clinical stability with acceptable oxygen saturations. They must have acceptable weight gain on a stable feeding regimen without concerns, and stable echoes without significant residual lesions that can lead to, as we covered, major adverse events. And finally, and maybe one of the most important things, is the parental readiness for care. So transitioning to home warrants ongoing vigilance. So many centers have implemented home monitoring programs. The first home monitoring program was described by the group from Milwaukee in the early 2000s. And the home monitoring programs allow in-home surveillance to detect psychological changes that may predict demise of these patients. These monitoring strategies consist of a home oxygen saturation monitoring and home weight checks. The frequency of this is different depending on the center and the program. Also, in addition to that, families are taught red flags. These are, among many things, heart rate trends, oral intake, and then additional signs of cardiac or non-cardiac illnesses. It's found that when using a home monitoring program in conjunction with the nutritional bundle, the National Pediatric Cardiology Quality Improvement collaboration demonstrated a 28% reduction in interstage growth failure. So by using these interstage home monitoring programs, there have been single center reports that have demonstrated a reduction as low as 2%. Again, the NPC-QIC, the National Pediatric Cardiology Quality Improvement Collaborative, reported a decline in their centers of an interstage mortality of greater than 40% between the years of 2008 and 2016. We established our single ventricle clinic in 2007. At that time, patients were either discharged home or to a medical home called the Children's Home, and then a select few would live with us. By 2010, all shunted single ventricles were being discharged directly to the children's home to follow there during the interstage period. All patients were discharged with a 3-ring binder in order to easily track their data that came back with them on their weekly visits. And review of our data demonstrated that after transitioning completely to the children's home, we had no out-of-hospital interstage deaths since 2011. Unfortunately, that program is not available to us anymore. And so we've been transitioning to establishing a home monitoring program. We've decided to use the software platform CHAMP, which is provided to us by Kansas City, and it stands for Children's High Acuity Monitoring Program. It gives us a remote home monitoring with the use of a parent-facing mobile application for data entry by iPad. And then we get, as a healthcare team, a web-based web portal that we can access anywhere. In addition to it being a data entry and a patient home monitoring program, it is a research registry, so able to share data from other centers and receive data from them. We are able to build in alerts. There's a 24/7 instant alert algorithm that is being set up, and we also would receive a daily summarized care list to the healthcare team. The other options we can have are weekly reports sent to the patients, the primary cares, and the primary cardiologists. The interstage team consists of many people, the physician, APP provider, nurse coordinators, neurodevelopmental psychologists, speech, occupational and physical therapists, and nutritionalists. Everyone is there to provide the support and care that these patients require, and to also provide the support that the families need. During this period of time, after discharge, there are significant risks for readmissions. The MPC-QIC looked at 815 patients across their 50 centers, and there were 66% of those patients had an unanticipated readmission. That median length of stay for readmission is only 2 days, because 67% of them are usually due to minor changes in clinical status, those red flags that we teach the families. 6% were due to only 6% were due to major adverse events. Of those adverse events, most of those were need for IV antibiotics, either because of a surgical or a respiratory infection. There was a low incidence, 16% or so of cardiac arrests, 11% was a significant aspiration event, and then only 1 patient had a stroke. So, final thoughts. Interstage period, historically known as high-risk time for mortality, but establishment of an interstage monitoring program has been shown to decrease this mortality rate significantly. Readmissions are common, but thankfully serious adverse events are not typically common. And standardized feeding programs, along with the interstage home monitoring programs, can significantly help to reduce the degree of interstage growth failure. Thank you. Yeah. Oh, yes. So I'm supposed to introduce the next speaker, Lauren Lorenzi. She is our very dedicated, very passionate neurodevelopmental psychologist that we use with our patient population.
Hello, thank you so much for inviting me to participate in today's course. I will be speaking today on neurodevelopmental care implications in the early stages of univentricular heart palliation. My name is Lauren Lorenzi Quigley, and I am a psychologist in the Heart Institute here at Children's in Pittsburgh, and the director of our cardiac neurodevelopmental care program. Early stages of care for this patient population with complex CHD is occurring within critical periods for brain growth and maturation, myelination, development of neural networks, and beyond. And the altered cerebral blood flow and brain immaturity during these sensitive developmental periods can lead to increased risk of developmental delay and susceptibility to injury. Along with the medical, surgical, and catheter-based interventions in this period, this can have implications for neurodevelopmental outcomes, which we'll discuss today. The prevalence of neurodevelopmental impairment in the population with congenital heart disease does range based on severity of the diagnosis, with the highest rates of neurodevelopmental delay or disability in our univentricular heart population, along with those with corresponding genetic diagnoses. It's estimated that 50 to 75% of children with complex CHD are affected and report some degree of reduced quality of life. We see the implications in various arenas of development, sometimes in terms of cognitive functioning and with lower IQ quotients, in terms of later academic achievement, language skills, both expressive and receptive. Visual spatial functioning is largely impacted in a large portion of this patient population, along with attention and executive functioning challenges, fine and gross motor abilities, and psychosocial maladjustment, both in regards to internalizing and externalizing problems. This period of infancy, much of which can be occurring in a hospital setting, comes along with high levels of stress and distress for both the patient, but also for the family, with heightened sensitivity for the infant to light, sound, smell, and touch. There are corresponding difficulties with early neurobehavioral and regulatory capabilities, which can be seen in feeding practices and sleeping, settling, soothing, in addition to autonomic and motor organization. And this can all have implications for early bonding and parental engagement. So what can we do and how can we support these patients and these families? And a lot of this comes down to developmental care frameworks, much of which has originated in NICU environments and is based on a maturation paradigm where premature infants show increasing behavioral organization over time and increasing gestational periods. But these can certainly be applied to that of the critical CHD child as well. This is a broad category of interventions designed to minimize stress in an ICU setting by providing structured care environments and being thoughtful about these various arenas here, including safeguarding of sleep, environmental support guidelines, positioning and handling of the infant, minimization of stress and pain, developmentally appropriate stimulation, as well as family-centered care. All of these interventions are designed to support, encourage, and guide the developmental organization of the critically ill infant. And we are seeing further research, especially in the CHD population, to show the positive impacts of these interventions in terms of neurodevelopmental implications, even in terms of length of stay, and notably in terms of parental stress and parental involvement in care. We can see the growing literature base in this arena showing the positive implications of individualized, family-centered developmental care practices in cardiac intensive care units. And the growth of this research has really been helpful in how we can best support these patients, especially in this interstage and early period. Individualized, family-centered developmental care has really been explored by the Cardiac Neurodevelopmental Outcomes Collaborative, and really work to unpack how we can implement some of these, as I mentioned, NICU originating interventions in a CICU environment. We really look at parent engagement and care as a core component of family-centered developmental care, but also these other arenas that were discussed previously of safeguarding sleep, minimizing stress and pain, non-pharmacological interventions for pain, and as well as sensitive and cue-based feeding protocols. So speaking to the family-centered care portion of this, we know that infants born with complex CHD are almost immediately physically separated from their parents, often physiologically unstable in the early periods, and are transferred very quickly to ICU settings for often very quick intervention. This can lead to inconsistency in physical closeness between the parents and the infants, reduced opportunities for parents and caregiving, and this has impacts on parental feelings of powerlessness. A prolonged inability to hold and touch their infants has great impacts on parental stress. And the stress that arises from this parental role alteration, really when looking into it further, comes from not being able to or know how to care for, touch, hold, comfort, or even protect the hospitalized infant in the varying acuity stages of their ICU course. 1 in 3 families are reporting symptoms consistent with PTSD, and these symptoms can remain elevated for up to 12 years post-CHD diagnosis, and arguably even longer. And we know that parental mental health is often a strong predictor of child mental health outcomes, sometimes even more so than medical and surgical factors. So really being thoughtful about how to support parents in this ICU environment is critical, as the stressors that are present for our infants certainly apply to parents and to families as well. Looking a little bit more closely about parent stress, the PCICU parental stress model developed by Lasanti and colleagues really looks at the varying implications for stress for the infant, the parent, and the environment, and the corresponding parental stress responses, both psychologically and physically. All of these cannot be modified, which we understand, but though areas in which we can make changes certainly can be in regards to the parental role and supporting and empowering parents to engage with their infant despite medical acuity, but in appropriate and sensitive manners. This parental partnership pyramid, which was developed by a group at Nemours, really investigated how parental participation in caregiving can be feasible in consideration of medical acuity. We've taken it a step further at Children's here in Pittsburgh, looking at how we can classify acuity on a more regular basis to guide parental engagement. So moving up this pyramid, you can see that the interventions are sensitive to the child's status at that time, and that should be discussed with the medical team on a regular basis so parents are engaging appropriately and offering support in a sensitive manner, and corresponding very consistently with the developmental team, but also the medical team to offer appropriate supports. So moving along some of those other domains of developmental care that I mentioned, we need to speak a little bit about positioning and handling in this interstage period. We know that there are motor impairments that are quite common for this complex CHD population that can be exacerbated by longer intubation periods and prolonged hospital length of stay. Musculoskeletal development requires adequate nutrition, proper infant positioning, and movement to prevent immobility-related developmental disorders and disabilities. Developmentally supportive positioning really hones in on 4 principles, which are flexion, containment, alignment, and comfort. And these can promote longer-term fine and gross motor skills, the ability for self-calming and self-regulation, energy conservation, and even head shaping and sleep hygiene. Additionally, awake prone positioning is crucial in this early period for development of head control and upper body strength, which is the building blocks for later developmental skills such as sitting, crawling, and even fine motor skills such as play at midline. All of these are areas we see difficulty for many of our patients with prolonged hospitalizations in the early period with univentricular lesions. The safety and feasibility of early physical therapy with passive range of motion or awake prone positioning, even after early sternotomies, has been demonstrated with improvements in motor outcomes in the long term. In this study here of holding and mobility with pediatric patients with transthoracic intracardiac catheters, they looked at over 1,300 patients and had activity and positioning documented with these catheters in place, and no major complications were noted resulting from patient mobility in this patient population, which I think is notable. There is great variation in holding and positioning practices across institutions when they've done surveys of developmental care for our pediatric cardiac ICUs. And so it's a growing area of that can be worked on to increase consistency and engagement in this area. Minimization of stress and pain and cue-based care are other really important areas in this domain. We know that undertreated pain can result in sensitivity to future pain experiences, altered stress reactivity, and longer-term mood and behavioral disorders. Integrating the use of non-pharmacological interventions like skin-to-skin care, closeness with family, non-nutritive sucking, this can prevent and even reduce infant pain when warranted, along with pharmacological management as needed. These interventions certainly demonstrate varying degrees of efficacy in reducing procedure-related pain in hospitalized infants, and there are a few small single-center studies that have reported the impacts in these areas with complex congenital heart disease, hopefully more to come. Cue-based care is another core component of developmental care. It involves reading the infant's behavior in regards to their attention, their state, their autonomic and motor systems, and adjusting the environment to whatever extent we can in the ICU to provide sensitive care and support infant brain expectations. Care often elicits stress responses, we know, and we've learned through the studies of often, again, premature infants that frequent activation of stress response systems can result in reductions of frontal and parietal brain volumes, reduced white matter maturation, and epigenetics changes. So attenuating these repeated stress responses through cue-based care can really have the potential to mitigate developmental disorders and disabilities in this patient population by preventing adverse stress-related changes in the brain. So timing, clustering of care, pacing of caregiving based on infant behavioral assessment and sleep-wake cycles can be really critical for neurodevelopmental outcomes. I would be remiss to not mention supporting feeding in terms of cue-based care. We know that infants with congenital heart disease and complex congenital heart disease at that frequently experience feeding interruptions because of invasive procedures, clinical status changes, hemodynamic instability, and use of sedatives or other medications, as well as the noxious hospital environment. And infants with CHD often lack the attention or oral motor skills and even the endurance to sustain oral feeding and are at increased risk for further complications with outcomes such as vocal cord paralysis, diaphragmatic paresis, non-invasive positive pressure of inhalation, or intestinal perfusion, and even oral aversion. All of these feeding challenges stated, we can work towards more cue-based feeding models and engaging parents in the feeding practices, no matter what manner of feeding is being offered, to hopefully mitigate some parental stress that is often associated with feeding, but also to optimize feeding outcomes and demonstrate safe oral feeding. Just speaking quickly regarding sleep, we know that their sleep deprivation can have impacts in terms of loss of neuroplasticity, altered behavioral patterns, and sleep is so critical for healing and growth and for neurosensory development that practices for protecting sleep, such as clustering of care, proper positioning, being sensitive of the environment, as well as skin-to-skin care or holding for appropriate periods of time to allow for full sleep cycle completion are all thoughtful interventions in this modality. Being aware of the CICU environment and the implications for neurodevelopmental functioning is also important, although sometimes hard to modify. The American Academy of Pediatrics recommends sounds under 45 decibels and never above 60, although our ICUs, with more research again in the NICU setting, but more coming from cardiac ICUs with decibel levels upwards as high as 120. And this can have impacts on growth and development. Cochlear damage can occur or and other physiological implications in impaired sleep. Quick interventions to do would be rounding away from the bedside, monitoring of alarm volumes and silencing of phones quickly, plus the delivery of positive auditory stimulation where parents come in here in terms of reading, music, and parental voices with the exposure to language, which we know to be so critical for later communication development. Similarly, there are recommendations through the World Health Organization for the degree of exposure to light, and there's growing evidence to show that minimizing exposure to direct overhead lights, if medically appropriate, the shielding of the patient's eyes, and cycling of lighting and exposure to natural light during the day can have positive implications for sleep, for circadian rhythm development, and also for delirium management. One of the ways we've implemented many of these practices in our institution is with neurodevelopmental rounds. And this is based off of that developmental care framework we've been discussing. They occur weekly at bedside with a multidisciplinary team. We generate goals that are inputted into the EMR and are outlined at bedside with developmental posters. We really aim to have robust conversations with both staff and with families to talk about developmental progression and engagement in ways that we can normalize the ICU environment to still allow for growth in terms of developmental milestones, even when receiving this critical care in our ICU settings. And we've seen positive implications for infant-parent relationships, having more regular evaluation of the infant's behavior and the environment, and ultimately with these developmental recommendations, hopefully easing the transition to home. And this is not a one-person job, it's a multidisciplinary venture for sure. We work closely with physical and occupational and speech therapy teams, with child life, and with behavioral health, and like myself, and along with our nursing and medical team colleagues. And this really is a team effort to implement some of these neurodevelopmental care practices in our ICUs, but we know that the outcomes that we can see later on can certainly be improved by really being thoughtful about the interventions offered in this critical time point in the early stages. So I really appreciate the chance to speak today. I apologize for not being able to participate in the panel, but please direct any questions my way regarding any of these topics. So thank you so much.
All right, thank you everyone for these wonderful talks. I think all the faculty did a fantastic job with these presentations. So we're gonna go ahead and move forward with the panel discussion and try to answer as many questions as we can in the next 20 minutes or so. If I can have the Zoom here on the screen. Do we have Dr. Toledo, Dr. Joanne also on the chat? Can't see. All right, fantastic. And while we're checking for that, I can start with a question. There was a question about the use of ECMO from Dr. Grace in Qatar about the use of ECMO after the stage 1 operation.
So basically, we use ECMO after the first stage operation when there's like a signs of low cardiac output syndrome. Sometimes that the kid can having some hypoxemia during the OR. If there's a large needs of inotrope, and those will be the considerations to use ECMO. Most likely the scenario sometimes that kid get delayed the surgery, over circulating, and at the time of the operation can be try to come out, develop a little bit of the low cardiac output syndrome, and the inotrope is high. And through the years, we've been understanding some of those kids, you might push it with a high epinephrine doses and a little bit of vasopressin, but there's a high chances they're gonna rest it in the CICU. Sometimes it's better, to manage on ECMO the first 24, 48 hours and then try to come out. Sometimes there's at that point, you're in high speed, low altitude. You also are bleeding more than you expected. So those are the consideration. And more if it's a VT shunt that you can overcirculate suddenly, those are the indications, basically, to go on ECMO for us. Now, if there's hypoxemia right away in the OR and, we come out, we already look, the shunt looks good there. I mean, that's our indications to go on ECMO and go for a cath lab and revise the surgery. That would be the other indications.
Thank you, Dr. Castro. While I have you, another question for you and for the rest of the panel. Is it better to delay the Norwood stage 1 procedure after a first month and proceed with early pulmonary banding in the first 24 hours? And this question comes from Dr. Luis Bravo. Have we done this strategy before, or have you guys seen this strategy been done before?
So doing a PA band before doing the stage 1, yeah, like a year ago, we have a kid that was over-circulating too much. We opened the chest in the CICU because the lactate was going high with the PA banding. And then in the next 2 days, Dr. Morel performed the Norwood, and we didn't have any issues. I know that the paper that Gilgar Warnowski and Ricardo Munoz, that group, now they try to reinvent the wheel on that. They argue so much that this is going to be the next way to manage these Norwoods. I mean, it's an strategy after you did all the maneuvers to not to over-circulate. I mean, that can be a maneuver. But, I think we, in very selected case, I can say through the years, we've been doing that maneuver.
It looks like Victor Morel wanted to comment on the use of ECMO. I don't know if you can connect him.
Let's see if we can have...
He's the boss.
In the meantime, there was another question about, was it atrial decompression in patients who have left ventricular sinusoids?
Yes,
right?
if you want to comment on that, Dr. Kreutzer, in the meantime.
We actually have not had a lot of, we would decompress the left atrium if it needs to be decompressed in somebody who has aortic atresia and left ventricular sinusoids. There have been very few rare patients in whom we have moved towards heart transplant in those patients. But historically, I don't remember us not proceeding with a pathway because of seeing those sinusoids. Is that correct, what you're saying?
Yep. And then there was another question for you, Dr. Kreutzer, about the fetal intervention for aortic valve disease. At what gestational age would you do that?
I just wanted to clarify, we here in Pittsburgh, we only did about a handful of fetal interventions, which were technically successful. That happened a few years ago, and we have not, we do not currently have a program for fetal intervention for balloon dilation of the aortic valve. I'm always ready to do it, but because of some of the considerations that I discussed previously, this is not something we have taken on from a programmatic perspective. In general, the timing is between about 20 weeks to 30 weeks is when you do the fetal intervention. In the reports, there are some that were done up to 32 weeks. Obviously, the benefit of that is less because the chances of remodeling that left ventricle are going to be less, as the heart may have already arrested in terms of growth by then.
Fantastic. And I see Dr. Morel has joined us as well.
Yeah, hi. Thanks for allowing me to say a few words. But when we look at our ECMO use, I think it's a very important tool for us, and it's been extremely successful at saving lives and allowing us to have an extremely low mortality with the Norwood. The main indications is usually desaturations in the OR, and the need for, like Mario mentioned, the need for high inotropic support, and at times, poor ventricular function intra-op. We usually, it's only very short-lived, so we usually the following morning, give a trial to come off. And if the patient does not come off, the patient goes to the cath lab. So we don't let patients sit on ECMO for days before we start. So we have a protocol pretty much. They put on ECMO the day of surgery, they go to the ICU, but the next morning, we clamp them. If they're not ready to come off, then we look for reasons why they're coming off. The most common reason might just be a shunt issue. The nominated artery looks narrow and needs to be enlarged, or there's stenosis somewhere. But those are usually, we find ECMO very useful, and it's proven to be a great tool to get these kids through and survive and thrive. Thank you. That was it.
Thanks, Victor. That was great. A follow-up question came also on the use of anesthesia in this population. Obviously, this is a vulnerable population. Is there any, any medications you would avoid or you would, like reduce the dose for in this population, Dr. Bray?
Yeah, I think there's a lot of medications to avoid. Propofol, for being one, is not a big part of my practice and tend to stay away from it from the sort of afterload effects that it has on the circulation. I use a lot of, in general, the main drugs that I sort of stick to just because I've found them to have very favorable hemodynamic profiles, are opioids, with the mainstay being fentanyl, midazolam, ketamine, and Precedex if the kid's heart rate would tolerate it. And those are mostly sort of titrated, and the dose is tailored both to the kid itself, but also what sort of procedure or intervention we're doing. More so based on, am I inducing the child, and then are they going to need to be intubated? Or is it something that I can simply sedate a baby for, like a PICC line, or the CT scans, or something like that? Those doses tend to be a little bit smaller, and then every once in a while, the way our setup is we'll have an anesthesia machine. For instance, for CTs, we typically would not intubate a lot of those kids for CT scans. We would give a little bit of either IV midazolam or IV ketamine, and then a lot of times we'd actually use nitrous to supplement and sort of tape the kid in place. So I think it really depends on what your goal is, as far as what drugs to utilize and the doses to utilize.
Fantastic, thank you. Another question for Dr. Yvonne Morel. Like with the interstage program, and while we're trying now to transition into the home monitoring program, would you envision some patients who may continue to stay in the interstage period? Like, are there some high-risk patients that you wouldn't send home with this physiology?
Yes, definitely. There are going to be patients that hemodynamically we just don't trust in order to send them home safely. So we've always had those type of patients. Even when we utilized the children's home, we had patients who required ongoing IV milrinone in order to sort of balance the QPQS well enough in order to allow them to grow and to eat. And so those patients will continue to exist, and they won't be joining their colleagues at home. Yeah.
Fantastic, thank you, Yvonne. I have another question to Dr. Colvin, Erin Colvin, who is our fantastic APP on the surgical team, about the family experience in this patient population. Like, they stay in the hospital for a long time, and obviously this is a complex type of congenital heart disease. So any words for families, or any, any suggestions for the families to stay resilient in face of this complex congenital heart disease?
I think it's a great question. I think from the beginning, we need to engage the families, and even kind of piggybacking off of the question Dr. Morrell had answered, some of our patients we've had where families couldn't go home because whether it was their social situation or they just didn't have that ability to safely take care of the child or even to the children's home. But I think engaging the families early, teaching them what they're going to need to know, having them be part of the care, but also balancing that with taking care of themselves and making sure they're taking care of themselves so that they can take care of their child even in the hospital or when they go home, because it is a lot and we're asking them a lot, and they're staying here for a long time at this point, some of them for 3 and 4 months. And I think the relationships that they develop with the providers on the floors and the care team, I think is really important too. And we're able to notice if family's not feeling well, if they need a break, and I think giving them that is really important. And involving our neuropsych team and doing assessments on the families, I think, is important as well.
Fantastic, thank you, Erin. A question to Dr. Lamford. Like, we have recently a few patients who had single ventricle physiology and a tricuspid or a common AV valve with severe regurgitation. So how would you how would you start the palliation for such a patient with severe AV valve regurgitation?
It's an ongoing discussion here. I think we have one of those in-house right now. I think with that particular infant, we did hybrid.
We did the hybrid and then to see whether things would improve over time. But that is the most difficult, one of the most difficult patient populations. Since if they're born with significant AV valve regurgitation, it does not tend to get better with time, with the volume loading and the afterload that we do with the hybrid.
Yeah, and I think that's the difference, right? This patient was born with significant AV valve regurgitation. We palliated him. He ended up not being able to be extubated, got trached, and we've maintained him on IV, milrinone for hemodynamic stability. And so to sending him to a Norwood, it doesn't seem to be the correct path for him, as opposed to someone who did not have significant AV valve regurgitation at birth and developed it in the presence of sort of bypass Norwood hospitalization. I would probably consider doing a Glenn to offload that single ventricle and see how they do after that.
I would imagine that in those patients, essentially a hybrid is almost like a bridge to transplant.
Yeah. And then while I have you, Dr. Kreutzer, you talked about the hybrid using the flow restrictors. So, do you do that as an alternative strategy to the hybrid, or are there certain patients where you would, rather do the flow restrictors in?
I mean, we've only used 2 patients. We use flow restrictors. Patients do, for whatever reason, we did not think they were good candidates for operation. And the idea was one is as a bridge to transplant. The idea is to control balance the VQ and the QPQS without having to invasively open the chest and do the ductal stent. So keeping them on prostaglandins and doing the flow restrictors obviously is much less invasive than opening the chest, putting a line in the MPA, delivering the PDA stent, and then putting the bands. But one of the issues is that we still haven't perfected that technique, and I know other centers have used them more. But the flow restrictors do tend to move distally. And I don't know, Victor may have had a chance to remove one of those, but I don't know if you can comment, Mario, on what would you think about removing those flow restrictors inside the pulmonary arteries at the time of the Norwood or a transplant, and also how you deal with the pulmonary artery banding and the stent in the hybrid, in the PDA, extending often into the aorta? Is that a technical issue?
for that answer, I don't know if Dr. Morel wants to answer, but this is a patient that we were involved in the heart transplant. The only one we removed the flow occluders, and we didn't have any issues during that, but it was a few months after they put the flow occluders when we did the transplant. So this kid did not have any problem, you know. But it's reporting the literature that they're high risk, they can burst the PAs. And in this case, we were gonna go for the transplant, so it was more easy. But if you cannot tolerate the palliation and you need to repalliate, that's when the major risk on consideration. So our experience is only for 2 cases.
Mm-hmm. Fantastic. I see Dr. Morel also on the screen. Dr. Morel, anything to add?
No, I agree with what Maria said. It's we taking out those flow restrictors wasn't that difficult. That those restrictors were there for, I want to say 3-4 months, and it worked out okay. The other question that Jackie posted related to the stenting and having stents that protrude into the descending aorta, I have to say that as technology and the years have passed, and now we stent all kinds of stuff from MPAs to branch PAs to aortas. It's somewhat inconsequential nowadays. That I think we're getting used to dealing with stents now. It's part of what we do every day.
Fantastic. There was a question about how would you decide about the size of the BTT shunt or the Sano in a certain patient? Like, is there kind of like, rough rules you go with, or do you look at the SAT when you're coming off, or how would you decide about that?
So usually it's based on the kilograms of the patient, and most likely our kits is there between the 3 to 4 kilos, and most likely we're gonna use a 3.5. I mean, some surgeons decide to use a 4 millimeter, but sometimes they over-circulate more. So usually most of the time 3.5, because most of these babies are between the 3 kilos. We don't do nobody less than 2.5 kilos, and usually we never use a 3 millimeter BT shunt. And the Sano, usually we use a 5 millimeter with a ring with the donking technique.
Fantastic. I've seen you sometimes putting some clamps around the shunt if you feel that's going to result in over-circulation right after surgery.
So usually sometimes we use some clips to regulate the flow on the BT shunt, but it depends. If the kid is over circulation, sometimes we put those clips to help us. Now, if the kid is on ECMO, we usually, sometimes if we're so vasodilated and we need to, recover the systemic perfusion, we partially clip the BT shunt. We never, on ECMO, clip completely the BT shunt because there's been reports about lung ischemia and complications for the lung.
Mm-hmm. Fantastic. Thank you, Maria.
And those clips can be easily pushed out of the way with a balloon.
Great. Thank you. Just speaking about the hypoxemic mix, is there a role for the hypoxemic mix in the post-operative period? I know we use it in the pre-op, like pre-Norwood time, but would you use it also post-op, or would you more try to balance it with other measures?
I would say that typically we don't use hypoxic mixture in the postoperative period, and if we do need to, that's probably a call to Mario or the cat doc. Typically, it's a preoperative management strategy.
That's fantastic. One question, we talked about the restrictive atrial septum, mainly in the cases where there is a hypoplastic left heart. Have you seen a lot of restrictive atrial septum in a hypoplastic right heart, like in a tricuspid atresia or pulmonary atresia with intact septum?
We've certainly had them. Usually it's later. It's not in the newborn period, and I can recall 2 of which we just actually went to the Glen when they presented in sort of low output.
Mm-hmm.
Sometimes the manifestation is a low cardiac output as opposed to anything else because the venous system is very compliant. So it's rare to see a significant gradient across that PFO. And so the appearance of distended right, hepatic veins, IVC, and a low cardiac output can really be the sign. And it's rare to happen, like Libby said, right away, but often a few weeks later, that you can see that chronic restriction causes low cardiac output and it needs to be addressed either surgically or in the cath lab.
Fantastic. Thank you very much. That was the last question we had. So, Dr. Lanford, you have another question.
I have two anesthesiologists in the room. One of the issues is those of us who follow these complex univentricular hearts is timing of what I would call maybe semi-elective surgical procedures, sort of plastic surgery, circumcision. Is there a time that you think is better? Like post, I mean, usually we don't do them in the Norwood stage, but post Glenn, post Fontan,
Yeah,
when
I was
would
about
be?
to say, ideally not first stage. I think kids who are second stage, they're doing well at home, their AV valve is good, they're well oxygenated. I think if say for clefts and things like that, it sounds like that's what you're talking about, to increase their PO intake and things. I think in my experience that is totally appropriate and we can get those kids through those procedures safely. At our institution, afterwards, all of those kids do go to our cardiac ICU though. So I think having a well-rounded ICU that is capable of handling the kids' pathology and physiology apart from their plastic surgery case is also important to sort of maintain good outcomes and stuff. I think if you get them past the first stage, the second and Fontan stage, then a lot of those procedures can be done safely.
They're very simple to manage. In fact, I'd argue that the Fontan kids, the tolerant anesthetics, a little worse than the Glenn kids.
I would agree with that.
And that's what I think from a cardiology standpoint, but we have many of our supportive services want the surgeries to be all done. Yeah. So it just helps me with that discussion.
Does that ever happen?
No, but I don't want to get there because then they'll never get their, if it's semi-elective and it's very important to the family, and as we've just heard, these families are really striving for normalcy in any way that they can. And so anything that we can do to help move that forward. The ventilation, negative pressure ventilation, is anybody using it clinically?
We don't use it. I just brought that up to emphasize that how important spontaneous ventilation is, and you can augment it should you if you need to. I think it does pose an interesting question though, because if you think about all these adults who wear CPAP for OSA all the time, that is a nighttime treatment, and it's fairly ubiquitous. And this is just food for thought, but if you took a Fontan patient and you put them on negative pressure ventilation at night and you augmented their cardiac output and pulmonary blood flow for 12 hours of the day, what does that do long term? I think the question of that is largely unknown. But it would seem to make some logical sense that perhaps those patients would do better long term and hopefully have a longer sort of transplant-free survival.
Dr. Osee, do you want to talk about your research project?
Yes, so that's such a very interesting concept. So we have like a non-invasive device called the PEP body device, where it looks like a whistle with like a few holes in it. And the patient, like we're asking the patients to take a sniff, like deep breath, and then blow through that device with an idea of trying to generate pressures similar to the pressures that we create with biphasic ventilation that you presented, Dr. Bray. So we're hoping to look at we looked at the acute effects, and it seems to have a similar effects to what you presented nicely in that study. And now we're trying to do a more long-term study to see if we ask them to do it a few times a day, if it will have any permanent effects on their cardiac output and their quality of life. So that's something to be to be studied in the next few years. All right. Thank you very much, everyone, for the great questions, and thanks for the audience. I don't have more questions. I think Dr. Kreutzer will give some final remarks, but thank you, everyone.
Thank you so much, Tarek, and thank you to all the panelists and the speakers, especially, thank you for the guests that came to Pittsburgh for the presentations. I also wanted to thank James Ferris with Massive Media for the IT support and the Congenital Heart Academy for transmission, as well as Katie Scollin and Room for their organization skills. I don't know if Victor wants to make a few comments from Tampa, but it's been a true pleasure having you all, and I really appreciate all the interactions and the questions that came across.
I just wanted to thank everybody for participating. We hope that this continuous series, it's educational for everybody participating. We'd love to hear your comments. And again, thanks for everybody who participated. Complex problem. We're still trying to solve it. Hypoplastic left heart syndrome in the ventricular hearts. It's something that we'll keep talking for many decades to come, I'm sure. Thank you.